Good morning, and welcome to the 11th Annual Interprofessional Education Collaborative Spring Symposium. As you know, the theme for today's symposium is the science of pain and the art of healing. My name is Kurt Sear. I'm a senior lecturer in the College of Pharmacy and co-chair of the Spring Symposium Planning Committee. It really is amazing to see all of you here. When we first came to look at the forum, there was a basketball game going on over there, and we weren't really sure how it was going to turn out, but it looks wonderful, and all of you look amazing out there, and it's great to see so many programs represented. This is really the first time that the Spring Symposium has had this many students all in one venue. And hopefully in the future, the Spring Symposium will continue to be here in the Alphon Forum and similar other interprofessional events. As you can imagine, planning an event like this requires a group effort. And you saw on the slides that were scrolling the tremendous number of people that were involved in planning and making this day happen. I would like to take a few minutes to thank the individuals involved in this incredible endeavor. The first person to be recognized for her leadership is Dr. Shelley Cohen-Conrad. If you could stand and be recognized. She's the director of the Center for Excellence in Interprofessional Education and associate professor in the School of Social Work. And as you can see from the list on the screen, there are too many people to thank individually, but I hope you can appreciate the number of people who have been instrumental in making this day a reality. I want to highlight the diversity of UNE programs represented on the committee and thank everyone involved in the planning of this day. It was truly an interprofessional effort. I would also like to recognize three individuals who did a tremendous amount of work, if they could also stand. Chris Hall, Amy Pednall, and Katie Gardner. Chris. They played a key role in everything you are going to experience today, including the organization and setup of this remarkable venue. Finally, I have the great pleasure of introducing my fellow co-chair of the Spring Symposium, Dr. Ed Bilski, who will officially welcome you to the symposium. After completing his doctorate in pharmacology and toxicology at the University of Arizona and teaching at the University of Northern Colorado, Dr. Bilski joined the faculty at UNE in 2001. He has been very productive in his career at UNE, conducting translational research in the areas of pain, addiction, and other neurological disorders. Dr. Bilski has more than 65 publications in peer-reviewed journals. He has received more than $5 million worth of research grants, and he is the co-founder of two Maine-based biotechnology companies that are developing innovative medications for the treatment of pain and addiction. Dr. Bilski is also the founding director of the Center for Excellence in Neurosciences and became the Associate Provost for Research and Scholarship in 2011. Please join me in thanking Dr. Bilski and the other members of the committee for organizing the keynote and breakout seminars for today's symposium.
Good morning, and thank you, Kurt, not just for the introduction, but also your leadership in helping us plan and deliver this day-long symposium. And again, good morning to all of you, our students, our faculty, our staff, and all our special guests that are in attendance today, as well as those who are participating in this symposium through the live streaming on the web. President Rippich was scheduled to be here and give these opening remarks, and unfortunately she had to rush to Ohio to be with her mother, who had taken seriously ill yesterday morning. The President was truly looking forward to this special event. She had blocked off the entire calendar day to participate in all of the different aspects of the symposium, including our keynotes. She wanted to observe the small groups and seeing our students in action, and also sit in on some of the exciting workshops that were planned this afternoon. Our thoughts and prayers are with Danielle and her family at this difficult time and facing this unexpected situation. As Kurt said, this marks our 11th year of doing interprofessional education and the Spring Symposium, and we're celebrating, however, a number of firsts today. One, we're in this beautiful Alphon Forum, and when they announced this $10 million gift to build this building, it wasn't just about the athletic programs. It was also with in mind the interprofessional health delivery workforce training of these students, and that we're going to provide this outstanding care to the communities that they live in. Their gift has enabled the University of New England to be a lead in preparing healthcare professionals who are developing and delivering integrated healthcare in the 21st century. And so today, in hosting this symposium here in the Alphon Forum for the first time, we celebrate and honor their commitment to the University of New England and to the state of Maine. As we enter our second decade of the symposium, today's event is also our largest ever. We have close to 1,000 of our students participating at the university-wide. All of the colleges are represented here in many of the professional programs. And when I first arrived here in 2001, they had a program called I2H2. It was the predecessor to the Interprofessional Education Collaborative. It was just getting off the ground as a grassroots initiative. It was based in the College of Health Professions, and there was a select group of faculty that had innovation and a long-term goal in mind to deliver interprofessional health training. At the time, there were skeptical colleagues, they were facing other challenges, skeptical students, they had very scarce resources, but they persevered. And over time, they brought in more people, more programs, and more colleges to build it into the robust and vibrant program that it is today. The Center for Interprofessional Education is not resting on its laurels as it advances its first team of UNE students onto the Clarion Case Competition, which is going to be held this month in Minnesota. We congratulate the students that were the winning team chosen through competition to represent the University of New England. We are also waiting a word on the outcome of a recent site visit from the Arthur Vining Davis Foundation. And there's also a rumor spreaded around that Chris Hall and Amy Pendault are working on next year's symposium already. If you see them today, please encourage them to have a drink, take Friday off, and get back to work on Monday for the 2014 symposium. A parallel success story with the University of New England has been the neuroscience and pain programs. This came out of another grassroots initiative led by faculty who shared a passion for studying the nervous system, generating new knowledge through research, and applying this knowledge to improve the lives of the people that live in our communities. Early efforts led to broader cross-college coordination of faculty hiring and securing of external funding to support those efforts and grow the program. Under President Ripich's leadership, she formed a number of centers of excellence, including the Center for Excellence in Neuroscience in 2008. There's been many successes along the way, including the recent awarding of a $10 million NIH COBRI grant that Ian Meng is the principal investigator on. It's an amazing accomplishment for a university our size and relatively young university. We continue to build on that. We announced this NIH COBRI grant in August of this year, and in part, we got feedback from community members that were interested in what we were doing around chronic pain. This really helped define today's session and this conference because it was this connection with the press releases that the community members responded and asked us what we were doing, including a wonderful family that you'll see featured later today from Winnipeg, Canada. They contacted me and asked about the programs that we were running, and they wanted to see if there was any hope that we were doing some clinical trials. I had to inform them that we weren't doing clinical trials. It was all basic science research, but they wanted to participate and wanted to share their story. And again, you'll get to see them in action. So on behalf of my co-chair, Kurt Sear, we recognize Shelley Cohen-Conrad as the center director, Chris Hall and Amy, and Katie Cardner as well. They are the core team that has brought together many of our committee members, our faculty and student leaders, and our amazing staff to capture the very human face of today's theme of chronic pain. I welcome all of our speakers, presenters, and special guests, including members of our board of trustees. I believe David Biondi, Nancy Pond, and Mike Morell are in attendance. Mike is going to be joined by his wife, Maryland, who has shared her own story of overcoming significant life obstacles, including chronic pain. It's also a special privilege to acknowledge several of our student members. If they could stand quickly, Mike DePice, Lindsay St. Louis, and Kristen Brusky, who created this Community in Pain video. This is a compelling video that you're going to see the full version of in a little bit later in the session. And of course, I'm going to extend a special thanks to the many individuals who shared their very personal experiences of chronic pain, including from the Chronic Pain Support Group of Southern Maine, Paula and her family, Judy and Mel, her parents who are in attendance here from Winnipeg, artist Karen Muzak from Texas. We sincerely appreciate the efforts all of you have provided in sharing your stories. If you've not already had an opportunity, please see the beautiful work and photographs that are out in the hallway here. Those are the works of a number of people, including Holly Haywood, Mike Vickery, Kathy Plurd, and Chris Hall. They've been instrumental in bringing this Art of Healing today's theme. The paintings and photographs and videos that you're going to be seeing truly reflect a unique perspective that helps educate all of us in the care and healing not only of the body, but of the mind and the spirit of those afflicted by chronic pain. At this point, I asked Dr. Cohen Conrad and Ananda Cole to join me on stage, along with senior neuroscience major Lindsay St. Louis and UNE alum Mike DePice. We're going to make a short presentation with Tara Hill from the Maine Cancer Foundation. We're very excited about a recent award from the Maine Cancer Foundation to extend a lot of the work we're doing here today and highlighting people who are facing cancer and also having significant pain. Through their generosity, they are providing us a check for $22,500 to continue to build on some of the excellent work that our students and our faculty are doing. So with that, please welcome and congratulate these people who are involved with this. Okay.
Hi, thanks very much. We are so pleased at Maine Cancer Foundation to have received this grant proposal, and the committee was really thrilled that we would be able to fund a project that was going to impact the area of chronic pain. It's a little understood, but now really recognized as being an important part of an individual's cancer journey. So thank you very much, and we're pleased to present this check.
We're good. We're not used to the paparazzi here. So now it's my pleasure to turn over the microphone to Dr. Cohen Conrad, who will be introducing our first keynote speaker. Shelley's been at the University of New England since 2004, and that was after a 3-decade career working as a social worker with children and families. Her experiences working with these families and children living with chronic health issues underpins her passion for improving health care, and particularly the improvements of relational and caring practices. Shelley is the director of the Center of Excellence in Interprofessional Education at the University of New England and an associate professor in our School of Social Work. She is also the co-author of a new book, Child and Family Practice, a Relational Perspective. I greatly admire the fact that she is also an original attendee of Woodstock in upstate New York, and she appreciates the music and the ethos of the Grateful Dead. In word of one of our students, she is one wicked chill professor. Please welcome Dr. Cohen Conrad to address the crowd and introduce our first keynote speaker.
Well, that definitely threw me off my game. Well, welcome. It's wonderful to see everybody here and to have this day finally come. I want to say that today's symposiums, before I introduce our first speaker, the symposium, The Science of Pain and the Art of Healing, was developed and produced by faculty, staff, students, artists, patients, and community partners, each with a passion for educating us about the complexities, mysteries, and lived experiences of chronic pain. This morning's esteemed speakers, David Thomas, Judy Watt-Watson, Kathleen Sluka, Candace Powell, and Paula Oran, bring extraordinary expertise to the subject from multiple and complementary perspectives. An event of this magnitude requires sponsorships from many, many people. And so I'm just going to add to the list and acknowledge the generous, and I want to say tireless support and energy of the Westbrook College of Health Professions, the Colleges of Pharmacy and Osteopathic Medicine, UNE Centers for Excellence in Interprofessional Education and Neuroscience, and the Office of Research and Scholarship. And I also want to acknowledge contributions from Cigna, the Graduate Program in Public Health, the offices of the Provost and the Vice President for Clinical Affairs. And finally, I want to thank Ed and Jill Bilski for their generous donation they made in honor of Ed's parents, who both live with chronic pain. So, I have the honor of introducing our first speaker, who I met last evening, and we had a wonderful conversation. Dr. David Thomas began his career in 1984 at the National Institutes of Health, working in the intramural pain research program. He currently holds the position of program official in the Division of Basic Neuroscience and Behavioral Research. Dr. Thomas is also an original member of NIH's Pain Consortium, and he leads their Centers for Excellence in Pain Education program. As you'll hear today, are major gaps in our knowledge about pain. Dr. Thomas is dedicated to better educating health professions across the professions about pain, its causes, and treatments. In a recent interview with the National Institute on Drug Abuse, Dr. Thomas commented, "Even a small improvement in pain education could have a huge effect, as each health professional works with many, many patients." Today, nationwide, there are only 4,000 professionals who specialize in pain medicine. To effectively reach more patients, it just makes sense to improve the pain education of all health professionals, even those who do not specialize in pain treatment. Well, Dr. Thomas is with us today to make a significant improvement in pain education. So please join me in welcoming Dr. Dave Thomas.
Good morning. Good morning. It's a little interesting to be introduced by a Grateful Dead fan when I'm at NIDA, but that's okay. I'm going to talk to you about a project I've been working on for the last 5 years, very excited about, Centers of Excellence in Pain Education, and it's run through the NIH Pain Consortium. And then I'm going to go on towards the end, as long as the card doesn't come up too quickly, and talk about this bigger reality that we found ourselves immersed in. And I think, in preparing for this talk, I've come to more of an understanding what that bigger reality is. So I'd like to share that with you too. But first of all, Centers of Excellence in Pain Education. The NIH does not have a pain institute. Congress recognized that as a problem, and instead of creating a pain institute, they created a virtual pain institute in 1996, the NIH Pain Consortium. And most of the institutes around the NIH do some pain research. NIDA, my institute, does a lot of pain research. And it's a way for us to work together on projects and promote pain research. For the most part, pain research. More recently, pain education. In 2008, a very good thing, this is my little personal, selfish story, the director of NIDA, a brilliant woman, Dr. Nora Volkov, became a director of the Pain Consortium. They had 5 institute directors that run the Pain Consortium. And I'm thinking, goody, I'm a pain guy at a drug abuse institute, but now she can come in and see what I can do. I can show off my background in pain, my knowledge, and how well I work with that group. So she sat down, the first meeting that she was at, and she said, when I was in medical school, I got almost no training on pain, and that's a bad thing. 100 million people in the United States in pain. Personally, I got no training. I think the Pain Consortium should do an initiative to increase pain education in medical schools. I'm like freaking out because I don't know anything about that. I'm a PhD, I like brains, I'm a neurobiologist, but I don't know about medical schools. You guys know more about that, or at the time knew more about medical education than I do. And I also don't know about the educational process. It's a whole science of education, and I didn't know that. So colleagues and myself, instead of folding at that point, we decided we need to figure this out. So we spent about 1.5 years trying to find out what is known about pain education. And there are only little bits, what we learned is that people don't know that much, and not much research is done on pain education, but in general, it's not taught very much in medical schools. And that people that come out of medical schools, MDs, don't feel very confident about how much they know about pain. We did some other searches, there's groups of how many classes are taught, there's surveys and stuff, we talked to professional societies. Bottom line is we thought that Nora was right, that there's not much pain education out there. Went back to the Pain Consortium, made a case, said maybe we should do an initiative on this, and they were like, well, you don't have that much evidence here. And they were right, we don't have much evidence. So we did what the NIH does a lot, and when we want more information, we'll do a workshop. So in 2010, we did a workshop where we brought in experts in education, in pain, brought in the VA, FDA, the Pain Consortium members, a number of other professionals that could help us, accreditation people. Is there a problem, and how do we solve it is what we asked. Spent a whole day working with them, and it was an eye-opener. First thing we learned is that pain is not taught much in medical schools. Beth Murenson was there, and she was working on a paper that's now published showing that the average medical student gets about 7 hours of pain education over 4 years. 100 million people in pain, cost the nation something like 3/4 to 2/3 of $1 trillion, and you get like a day of it, and it's spread all over the place, no real focus. And what they said was that at the schools, there's this institutional bias that just pain's not important. It's just not important. It's not the disease. It takes a back seat to the real problems. And this thought has been continued for centuries. So we definitely saw there is a problem. So the next question is, what do we do about it? And first thing we do in the government, well, can we spend money? Can we buy a curriculum? Ask schools to teach it? And the answer was no, they won't do that. You guys have a very packed schedule, and trying to squeeze something in, it's a zero-sum game, you're gonna lose something. So they said that won't work, but they told us of this option, the superhero option, if you will, that there are these people in medical schools that see the problem. They called them pain champions, people that want to increase pain education in medical schools, and that if we could empower them in some ways, that they could change from within. So we had an avenue. We went back to the Pain Consortium. They were interested. We started to get buy-in for this initiative. And the Pain Consortium is all volunteer. It's all on a volunteer basis. We have to ask for money and lobby for it, just like some might ask for a grant. They started to see the utility of it, and we started to do some more research, and we decided on a Centers of Excellence model of pain education, where we would fund pain champions at various schools to that could convince us that they could increase pain education in their schools. They know the territory we don't know, and we would require them to get letters from the school saying, we will do this, we will increase pain education. But we wanted to make this a really good project. We were starting to get a lot of attention on this project. And so we did, I talked to everybody. I even was in Europe at a NATO conference about pain education. And one thing that really stood out was that interprofessional education is the way to do things. People that learn together can treat together, will treat together, and if you treat together, you'll be more effective. And we need more effective pain treatment. So we put that in there. We added other schools. We started with medical students, but for interprofessional, you need nursing, dental, pharmacy, and other schools too, but we had to draw the line somewhere in our first project. And then in the fall of 2000, or the end of 2011, we put out an RFP, which is to the world. We're saying we have this amount of money. It wasn't much. We could fund each center maybe $300,000 per center, which is not huge by NIH standards, but it really could enable these pain champions, we thought. And the little secret is we put out this RFP, and now we're hoping for responses, and I'm praying for them, because if nobody responds or if we get bad applications, then all this 3 years of saying we need more pain education and these things called pain champions are out there. If they're a fiction, then we have a problem. Well, a couple months went by, and we're coming to the end of the deadline, and we started to get 2, 5, 10, 20, 30 applications, 40, 50, 56. We ended up with 56 applications, which was a lot. And in reading them, they were really, really good. They were interprofessional. They had not just one school, not 5. Some had as many as 20 schools banding together to teach pain education. So we're happy. We had to do this elaborate review, and I had to really tax my friends at the NIH, and then we got some outside reviewers. And we ended up with 12 centers of excellence in pain education. There they are. Oh, it threw me off. It was backwards. There they are. You can just read themselves. And also the NIH funders are listed there too on the bottom. These schools, there's 12 of them, but they really represent 100 different teaching units, 350 people, and there they are. These are the PIs, our pain champions that we thought were out there. And there are more. There's a lot more pain champions out there from the applications that we need to also empower in some way, and that's where the workshop will be about later today. This is from a kickoff meeting last July that we held. We invited 2 people from each of the centers of excellence and brought some people from other agencies too in, and everybody came. And one school said, can we bring 3? It's like, all right, you can bring 3. I said, well, can we bring 4? No, it's like too many. But everybody came, and they're smiling for this picture. They were smiling the whole time. The energy of these people, and they were talking as if they knew each other. Most of them knew each other. And when that RFP that we sent out that we hoped they'd respond to went out, they were like, it was buzzing around the network of the pain champions. They were calling people, did you see this? Are you applying? Yes, I'm applying. Isn't everybody? One person's mentor called their student. One person's mother called their child, said, are you applying? Yes, Mom, I am. It was unbelievable. I'm sitting there with something's going on here, bigger than, we didn't do this. I mean, we're tapping into some bigger reality here because this is a pain education initiative. It shouldn't be this exciting. Funny thing happened. They said, can we get certificates, like to put on their walls? It's like, I guess. Why? Certificates? Found myself signing 350 certificates. They were proud to be part of a movement, a cause. And then at one point I said, I'm getting a lot of flack at work for calling you guys pain champions because it sounds like you're into pain. And we're really, that's completely not part of this. But they said, no, we want to be called that. We want to be called pain champions, everyone. And it's because it's a cause, it's part of a movement that we tapped into. So that really got me thinking. They're still going today. They're increasing pain education in their networks right now. The courses are started. They're helping us create these interactive case-based scenarios. Those are going into production on a running basis, but they're fascinating little stories that they have to figure out what the patient's diagnosis is, what to do about their pain, and they're like little mysteries. They throw in red herrings and throw you off a little. So instead of just learning facts and figures, you're going to, if you take these, you'll learn the process of diagnosis, the act of treatment. So that's the first part. It's very exciting. But being asked to do a TED-style talk, I wanted to describe that other thing, that larger reality, and it made me kind of really think, what is going on with that? And I started to see, we have a movement, we have worrying about people that are oppressed. The people in pain are stigmatized, they're marginalized, they have self-doubt, and the institution is kind of against them. And in a sense, it seems like their civil rights are being denied. And perhaps this is something of a civil rights movement. Like the civil rights movement, and I'm comparing apples and oranges, but the civil rights movement of the 60s for racial equality, to fight racism, the fight of women, to fight sexism, gay people, to fight homophobia. In a sense, we might be seeing a movement to fight painism. And so, and just a few quick examples to kind of show you the stereotypes of painism. One, and you'll hear these sort of stories, there's the description of a hysterical woman with idiopathic pain. And we don't use hysteria quite as much. It's kind of sexist term in the way it's used, but other crazy terms are used to describe people with idiopathic pain. And that's acceptable. You hear it and it seems reasonable to people that say it. Well, idiopathic means you don't know what the pain is. Not diagnosing is not a diagnosis. Failure to diagnose is not a diagnosis. People don't have a case of I don't know. And then, yeah, I'd be hysterical too if that was what you're telling me I had. Another thing I guarantee you in the medical field will hear this is I treat the main problem, I kind of let pain take care of itself. It's not my main issue. Well, the problem is you treat the main problem and you cure it. A lot of times pain continues. beyond that. Pain is its own disease. It can continue way beyond if you can cure the original disease. And sometimes the cures, like chemotherapies, can cause neuropathy and cause pain itself. You cure cancer, great, they're still in pain. And then there's the other problem with a lot of diseases you don't really cure. So I think the answer should be that instead of worrying about the disease, not the pain, do both. You can cure pain and cure the disease, or treat the pain, reduce the suffering. There's nothing wrong with that. And the last example is how pain is considered subjective. You'll hear that. And it's true. There's a working of the mind. You do feel it. I see pain in my own way. But a lot of times that's used to just say it's you. It's not us. It's outside the reach of medicine. I treat disease. I treat the body. Well, pain is real. 100 million people in the United States are suffering from pain. And they're not making it up. It's not an illusion. It's real as I'm standing here today. Another example of painism, I think, and you will hear this sort of comments. The military, I think, takes very good care of their patients. They don't think it's a fiction. I've seen it. I've been to Walter Reed, Grand Rounds, all over the military, and they treat their wounded warriors, and they take their pain patients seriously. The Centers of Excellence Pain Education, they're going to teach their students to do that. And I'd just like to point out that this is kind of surreal, because the whole time we were talking about who we were going to reach, it was you. It was medical students. You were the primary audience. And I think you're the key to stopping this painism in America. I mean, you can hear the things that happen. You're at a point now where you're probably not convinced that ignoring pain is a good thing. You haven't become part of that establishment, and if you resist that, you can stop it from happening. You're a lot of people, a lot of smart people, and you can resist it. We're not going to take a petition here at the end of the day and ask you to sign a piece of paper and say, yeah, we're against it. You're actually a big part of the culture, and if the big part of the upcoming culture changes, the culture will change, and we'll have a day where painism is a thing of the past, I hope. So I'd like to encourage you to keep caring about people, working interdisciplinary in a professional fashion to help people in pain. Keep caring and help stop painism. And thank you very much for your attention.
Good morning. As Dean of Graduate Studies and Public Health and as the Interim Dean of the Westbrook College of Health Professions, it's a real privilege to introduce our next speaker. And this is truly an interprofessional group. And I think what a wonderful example of how UNE is breaking down the silos. So this makes our next speaker particularly appropriate for this morning. Dr. Watt Watson is a pioneer in the study of pain and an advocate for raising awareness about the experience of those who live with chronic pain conditions. She views pain as a universal phenomenon that health professionals across all disciplines encounter in individuals at all ages, in all healthcare settings, and across all situations. Dr. Watt Watson is a professor emerita at the University of Toronto Lawrence S. Bloomberg Faculty of Nursing and was inaugural executive director of their Center for Professional Development. She is president of the Canadian Pain Society and was the inaugural chair of the University of Toronto Center for the Study of Pain interfaculty pain curriculum involving 6 health science faculties. The vision of the Center for the Study of Pain is to model interprofessional collaboration, to create and disseminate knowledge about pain, and to promote excellence in scholarship. To quote Dr. Watt Watson, "Access to appropriate pain management is a human right. To this end, interprofessional pain education helps to improve collaboration and the quality of health outcomes for patients." We are delighted to have Dr. Watt Watson speak to us this morning, so please join me in welcoming her to the podium.
Knocking down the silos. All of us, regardless of our profession, are going to be working with people experiencing pain in their families. And it's wonderful to see all of you here coming to an interprofessional pain event and curriculum. You're here, though, because your faculties value interprofessional education. And I want you to know that you're unique, because often students do not learn about pain together. If they learn about pain at all, it's often in professional silos. And this does not contribute to collaboration or a comprehensive pain management. And I'm just looking for my slide adjuster here. We were interested in knowing how we were doing in Canada. So several years ago, we surveyed the health science faculties in major universities, 10 of them across Canada. And we also surveyed veterinary medicine colleges for comparison. And the results were surprising to some, and they made the cover page of the Maclean's. Now this is backwards, so I'm just going to look here. It says, your dog can get better health care than you can. And here's why they said that. Only about 1/3 of the health science faculties had designated pain content, and very little of this was interprofessional. However, the veterinary medicine graduates had 3 times more pain content than the rest of us, 5 times more content than medicine. And the sad joke was that if you had a significant pain problem and you needed help, you should go to your local vet. And the surveys here in the US, the UK, and Australia actually had similar results. Our spectrum of practice is actually quite broad, and often we make decisions uniprofessionally, but multi-professional collaboration and interprofessional collaboration have both been found to have better patient outcomes. And so our education approaches need to support this. People have different ideas about what is meant by interprofessional. This is not what I'm talking about today. And I don't know if you have any time to watch television, but you do know that the media presentation of interrelationships professionally are not necessarily the best way to go. So in the context of education then, interprofessional is learning with, from, and about each other so that we understand our roles and expertise. We found over 10 years ago that from our survey we had minimal or no health curriculum related to pain and nothing related that was interprofessional. So we have developed and implemented now for over 10 years an interfaculty pain curriculum for these health science faculties, for 6 of them: dentistry, medicine, nursing, pharmacy, occupational therapy, and physical therapy, and I think something similar to what you have here. And you can see that when we did this 3 weeks ago, we had 944 students, again, also a large group. So our aims are to help students understand the widespread problem of unrelieved pain, that David referred to clarify knowledge and incorrect beliefs or misbeliefs, to discuss assessment and management plans, and to encourage patient-centered collaboration. The focus is on the person with the problem and not on the professional caregiver. You can see that we also have a large number of students, and that they vary both in their numbers and in their year. Medicine has the most students, followed by pharmacy and nursing. And when you look at the years that they're in, they vary also. Dentistry and pharmacy are in the 3rd year of a 4-year program. Nursing, OT, and PT are in the 2nd year of a 2-year program. Medicine is in 2nd year, so they have the least experience, the 2nd year of a 4-year program. However, they also are the largest number, so when we split them into small groups, they are well represented for support. Here's what we do. This is last year. The students are assigned to a group of 30. There are 30 of them in one group, and within that group they are assigned to interprofessional teams of 10, so that they work with those teams on cases. And we are very fortunate to have facilitators, again, across the professional groups who work with those with the smaller groups. As I think you are doing, we also use large and smaller multi-professional groups, so that you are here to learn about a specific topic, but there's very little sharing. But 50% of our curriculum is also in small groups, case-based small groups, where students learn about each other's roles, what is common and what is unique. This is what it looks like we have a mandatory 20-hour curriculum across 3.5 days. So on Monday morning, students hear an overview of neurophysiology. We want to make sure that they have a common understanding of key concepts, such as allodynia, when they're working with the patient scenarios. They do work in small groups, as I've said, 50% of the time on the Tuesday and Thursday mornings, and they do have facilitators to help them with that development. They do work alone in their teams in the other afternoons, and they have to present on the Thursday morning to their groups a comprehensive pain management plan. We wanted to have some standardization across the 30 groups. So we do have manuals for students and for facilitators. We include in these key resources, papers, and also the questions that guide the case development. We've spent a lot of time on the case development, the patient scenarios. They do come from real people, and they progress across from an acute pain problem to a persistent pain problem that they then have to write a comprehensive pain management plan for. And you all here have different experiences. You're going to be caring for some of the same patients, but also different patients. And so when we are deciding on what the scenarios should be, about which patients, we have tried to choose some common pain, people with common pain problems, such as around surgery or trauma, arthritis, amputation, and cancer. We want students to feel comfortable in working in the small groups, and of course, you all here too would bring different experiences to that. And so we do provide resources that help students to understand diagnoses, diagnostic tests, pain mechanisms, and case management strategies. We have done extensive evaluation. We modify the curriculum every year based on the feedback, but also we need to justify to our deans, to whom we report every year, that this is a worthwhile initiative. It hasn't always been seen as a worthwhile focus to take time out of a very compressed curriculum that you were all in to have an IPE piece. We use Kirkpatrick's levels of evaluation. We want to know the responses of students, faculty, and facilitators about the content. Was it realistic? Was it something that they were interested in? We also want to know about process. What happened with the groups? Did they work? Were their facilitators okay? We do pre and post tests so we know whether or not students learned anything. And we want to know whether or not the students can transfer knowledge to the actual practice. And we do this through the pain management plans. At the moment, it's very complex doing any evaluation in the actual clinical practice setting. And so we are working at that, but have had very little in this area. We do have all kinds of anecdotal feedback, though, that the students are doing well there. The plans are important, and here's what we are looking for. We want to see that they have clear goals based on the priorities of the patient's scenarios. There has to be multi and interprofessional input and a coordinated team effort. So it's not a list of what the medical student would do, or what the nursing student would do, or the pharmacy student. It is patient-focused and very much family-centered. There needs to be evidence of multiple strategies, pharmacology, physical and psychological strategies. And there has to be a plan to monitor whether or not their strategies worked. So it's patient-focused more than on the professional caregiver. The student comments are really important, and I just want to read a few. The cases brought all professions together, showed us we all had a valuable role in pain management. They made me realize how pain may impact every area of a patient's life. I was able to see and hear problem-solving approaches from different health professionals. I have increased respect for other professions and their roles in patient care. Our curriculum is about pain, but pain management happens in an interprofessional context. And so from these comments, we know that the students get this. I'm sure all of you know that it's not always easy working with people whose opinions vary from our own. This says, boy, the current is tough today. We might as well turn back. This is getting us nowhere. And there are times when, as we work together, I was really wondering whether or not this was going to be successful. However, working interprofessionally means respecting each other, listening to differences, and in a comfortable context. And so we did realize we had to all get moving in the same direction. And I think we did that by focusing on the person, focusing on what would be effective pain management for this particular patient. I have to acknowledge our very committed interfaculty team. They are representative of all of the different professions. We have deans, we have clinicians, students, all are a part of it. And it's a wonderful group of people to work with. for the sake of our patients, we need to stop learning and working in silos. We need each other, and because effective pain management requires collaboration and teamwork. You have a wonderful Japanese proverb on your website that says, "None of us is as smart as all of us." And there's no one profession here that's going to solve the challenge of pain alone. So I congratulate you, and I congratulate your faculty for knocking down the silos. Thank you.
Good morning. I'm Katie Rudolph. I'm the Associate Dean for Research in the Westbrook College of Health Professions, and this is such an exciting event, and I thank the Planning Committee for all of this. I'd like to introduce Kathleen Sluka, who is a physical therapist and a basic science pain researcher. She is a professor in the physical therapy program and program in rehabilitation sciences in the College of Medicine at the University of Iowa. She also has an appointment in the School of Nursing. She teaches in the pain research program, the neurosciences graduate program, and the molecular and cellular biology graduate programs. She has a very active research program, and it includes both basic science studies and clinical trials. In fact, she was recently notified that she was awarded a UM1 award by the National Institute of Arthritis, Musculoskeletal, and Skin Diseases. And this is an award that's a multi-component research project cooperative agreement that is to study, this is an award that supports large-scale research of very complex clinical problems that have multiple components. And this study will look at the use of transcutaneous electrical nerve stimulation in people with fibromyalgia. Kathleen is a Catherine Worthingham Fellow of the American Physical Therapy Association, and this is an award that recognizes professional excellence and a sustained effort to advance the profession of physical therapy. She was awarded the Frederick W.L. Kerr Basic Science Research Award by the American Pain Society, so you can see how well she spans both the clinical and the basic science worlds. She is currently the secretary of the American Pain Society and has served on councils in the International Association for the Study of Pain and has played numerous roles on their advisory committees. She recently served on a panel to develop interprofessional competencies in pain education. She's authored a book on the mechanisms and management of pain for the physical therapist and was the first person to develop a course in pain management for physical therapies in the US. She's traveled all around the world speaking about pain, and we're very happy to have her here. Please help me in welcoming her.
All right, so I'm going to switch gears a little bit, and I'm going to talk about there it is, sorry. I was supposed to look down here. So I'm going to talk to you a little bit about the problem of chronic pain. I'm going to talk to you about the problem of physical inactivity, and I'm going to hopefully convince you at the end that physical activity can not only prevent the development of chronic pain, but it's a great treatment for chronic pain as well. So chronic pain, you heard from Dave today, affects over 100 million Americans. And what he didn't tell you is that it costs over $600 billion in healthcare costs and lost wages per year. It's huge. And so it is a big problem. It not only is the sensation of a pain, it affects your quality of life, it affects people's function. It stops people from doing things. And in fact, one of the biggest issues with chronic pain is that actually moving produces more pain. And so people stop moving and they shut down and they become physically inactive. So I'm looking at this room, there's quite a lot of people in this room. How many people in this room do you think have pain currently? So by show of hands, how many people currently have pain? And look around your tables and around there. There's a lot, and a lot of people aren't telling you that they actually have pain. And how many of those people have had pain for more than, say, 6 months? It's a pretty big number. And it turns out that about 20 to 30% of the United States population has chronic pain at this point in time. But if you look at this, you see these pictures up here. Some of these people are familiar to you, some are not. Can you tell me which ones have chronic pain? I'd say you can't. There's people with fibromyalgia, back pain, trigeminal neuralgia, neck pain, rheumatoid arthritis, and there's perfectly healthy people. It affects everybody. It affects all genders, affects people young. So one of them is my son. He has migraines, and there's a picture of him when he was 17 years old. So it affects kids, and it affects adults of all ages. So this survey, which I think is pretty interesting, was done, and if you look at those numbers, it says that how many people have been pain-free in the last week, and there's only 20 or 30% of the population that was actually pain-free in the last week. And how many people have just one spot of pain? So everybody is sent to the doctor, the physical therapist, the health professional for a reason. And they come because they have back pain, they have neck pain. They don't come because they have pain all over the place. They come because somebody went to see them for their back pain or their neck pain. But almost nobody has pain in one spot. What is it, less than 20% of the people with pain have pain in one spot at one time? And most people have pain in multiple spots. So not only do you have to be focused on this interprofessional, you have to be focused on the patient as a whole, and the patient has to get beyond where's the pain. Is it a shoulder pain? Is it a back pain? Is it a neck pain? The other big thing that this survey did is they asked how much it affected people. And what you can see is that the greater and more spots you have, and the more widespread your pain is, the less function you have, the more disabled you are, the more impact it has on your mood. So we have to pay attention to these things, and we have to look out at these, because we aren't going to get people back to their normal life if we don't look at all aspects of their pain. So even if I cured their back pain, if I didn't think about the neck, the shoulder, and the knee, they still got 3 spots of pain. And that's still going to put them on the scale as higher than the one spot of pain. So what I want to tell you, and this was touched on again by Dave earlier, is that chronic pain is no longer a symptom, it's a disease, that we have to treat this as a disease. And this is a disease that I think, under many conditions, is hard to detect. We don't know what's going on with the patient, but we do know some things. We do know that there are some pathologies in chronic pain patients, and one of these things we think is an altered central modulation. So in the central nervous system, there are pathways that we know inhibit pain, and there's pathways that produce pain. And these are simultaneously active, and there's a balance between how much inhibition we have at one time and how much excitation we have at one time. Under normal conditions, they're even, and we have no pain. But when people get chronic pain, these get altered. We have less effective inhibition, and we have more facilitation or excitation, and overall, then our patients get pain. So you have to know that, because now we have to go on and talk about physical activity. Physical inactivity is a huge problem. And you can see these surveys. These are from the Centers for Disease Control. I pulled them off their website. You can go click on the website. There's lots of data there. But it basically tells you that most of the population is inactive. They don't do anything. So how many people in this room exercise 2 or 3 times a week? It's a pretty good room. You know, that's not normal. Most of my patients don't exercise. And if I do this in Iowa, I don't have as many people that actually exercise either. So it's actually, you can see 20 or 30% of the people are actually physically active on a regular basis. That's pretty low. Because of this, Bente Petersen out of the University of Copenhagen has coined a term that I really like. It's called the diseasome of physical inactivity. And it turns out that physical inactivity is a risk factor for many diseases. We already knew this. Cardiovascular disease we knew. Did you know it prevents cancer? It prevents dementia. It can prevent diabetes, and it can prevent depression. I added pain. She doesn't actually talk about pain, but I think it also prevents pain. So physical inactivity is a risk factor for pain. And if you're physically active, you can reduce your risk for this, and you can reduce the consequences of these diseases. So she calls it a diseasome because it's kind of a systemic disease problem. And it affects every aspect of so many diseases. It's amazing. So does it prevent chronic pain? So the Hunt study is a study in Norway that really uses the fact that they have socialized medicine and they can get all kinds of information on all of their people that use health care. And they just do a survey and find out how physically active people are and follow them over years and years and years and years, so decades. And what they've been able to show is that people who are physically inactive have an increased risk for development of musculoskeletal pain, chronic musculoskeletal pain. And that risk goes down the more active you are. So the guys that over 2 hours per week have a much lower risk than the inactive people. Well, chronic pain patients not only are inactive, they get less and less active. And in addition to that, very few of them, there are a few, and I'll give you that, but most of them didn't start being physically active when they came in to see me. You have many, many patients who walk in and have never exercised a day in their life and they're 50 years old. The most they've done is mow the lawn, or maybe they've shoveled the snow, but they don't do a lot. And our society is in a position where we don't do a lot. 100 years ago, we had, no cars. Maybe we had a few, but we had no cars, and we had to walk to get places. We didn't have computers. We didn't sit at a computer at a desk all day long. Now we do that all day long. Well, it turns out that people with chronic pain, and this is just showing the physical activity levels of people with fibromyalgia. I could show this for back pain. I could show this for other types of pain, osteoarthritis patients. They expend less energy per week, they walk less, and they sit more. And this is less than sedentary people that don't have pain. So they're physically inactive and they're really physically inactive. So in our lab, we were thinking about this a lot, but by complete accident, we discovered that if I stuck little rats in running wheels and I gave them in their cages and said, here, you can have these, I was trying to measure their activity levels because, chronic pain should produce reductions in activity. Well, so I get them all acclimated. I put them in a running wheel, and I induced this chronic pain model that we've developed in the lab to induce chronic muscle pain, and they didn't develop chronic pain. So this is showing you a decrease in threshold, an increase in responsiveness or hyperalgesia to mechanical stimuli before and after the induction of the model. The animals that were physically active didn't develop chronic pain. I kept saying, you did something wrong, go back and do that again. Right? You must have done something wrong. Something's wrong with the test. There's something wrong with the animals. And it took me a while to click on the fact that, well, maybe there's nothing wrong with the animals. They're physically active. All basic science studies, almost 90% of them in pain, are done in sedentary animals. We put them in cages and we have them walk around, and that's it. We don't do them in active animals. And it turns out that if we do, we have less pain. If we do an acute pain condition here, so if we inflame them, we give them a nice acute inflammation, they still develop pain just the same way. So it's preventing chronic pain, but keeping our warning signal for acute pain still there. So it's just preventing the development of the chronic non-protective pain condition. So we hypothesized and we think that what's happening is that physical inactivity results in kind of a lower level of inhibition, that we have a tonic inhibition in our body that level of inhibition is lower. So that when an insult, a low-intensity insult comes on, we get more sensitization and more activity in our neurons in our central nervous system. I'm sure this occurs in other places. We've been particularly excited about this particular area of the brainstem, which I'll just call the RVM. But this particular area mediates not only pain responses, but also motor responses. And so we thought it would be involved in this process. And indeed, over several studies, we've been able to show increased activation of these neurons in response to noxious stimuli, and that goes away in physically inactive animals. And that's just showing you the picture because I am actually trained as an anatomist and I have to show neurons. And all the little red dots are neurons. And you can see there's more little red dots in the animals with the chronic pain, which is pH 4.0, than there are in those that weren't. These are in sedentary animals. Do the exact same thing in physically active animals. So what we think happens in physical activity is that we have increased central inhibition. We've increased the tonic inhibition. That reduces its chance of becoming excitable, and we get less pain. And so we go back to the same site, we do that same test for activity, and those neurons don't get activated. In the physically active animals, there's no central activation. So the problem is, I'm skipping these. I thought I sent updated slides that didn't have these in here. We can also prevent the exercise-induced pain. So the last bit I want to tell you is not only can we prevent chronic pain, but we can also reduce pain. And we can reduce pain with regular exercise. And we know in almost every pain condition there is, exercise reduces pain. Regular physical activity reduces pain. And the RVM plays a key role in this pain production. The same site I just showed you about uses opioids. Same site also plays a key role in this. So it's not lost. We don't not only can prevent it, we can actually treat it with that. The issue, however, is that exercise is difficult to get people to comply with. It's difficult to get people to continue to do. It hurts when they do it, and even when we're not healthy, we can't get people to do it. So we need mechanisms by which to do that, and that's where the research needs to go. We need to figure out how to make people comply. We do know that physical therapists are sending someone are a key player in this. Sending someone and having supervised exercise programs is way more effective than handing them a booklet and sending them home. Nobody's going to do it. If the doctor says, here, we know exercise is good, go exercise, they're not going to do it. Who's going to do that? How many times has your doctor given you a list of instructions and said, go do this stuff, and then you get home and you go, what did he say? I can't remember. Oh yeah, something about exercise, but it hurts, I'm not going to do it. And you don't do it. You need someone to guide you through. If it hurts, we need to guide them through slower. We need to bring them up to speed. And the physical therapist is ideally trained to do that. That's why an interprofessional team who knows about what every discipline does is quite important. So I'm just going to summarize, and what I'm thinking here is really that physical inactivity is the abnormal state. It is the state that we aren't meant to be in as human beings, that people are actually meant to be physically active. Evolutionarily, we were physically active people. And our society's kind of put us in a position where we're less active. And so when we're physically inactive, we have less inhibition in our nervous system and less ability to stop little insults from causing pain, less ability to stop the transition from an acute pain condition to a chronic pain condition. Physical activity sets us up for that not to happen. We increase our tonic inhibition and we slow down the activity of those neurons, and they're less sensitized to small stimuli. And then we don't get pain. And so the goal is to get our patients to be physically active any way we can. Turns out it doesn't matter which way. Almost every exercise program works. There's been huge trials in chronic back pain patients, and they've even pitted exercise program against exercise program, and they all work. And it doesn't matter what. You got to get them to do what they will do. And you have to get them to do it on a regular basis. And apparently, according to the Hunt study, 2 times a week was enough, right? So 2-3 times a week. As physical therapists, we send people home and tell them to do exercises 3 times a day. Really? how many people would do exercises 3 times a day? You know, that's ridiculous. I can't even buy into 3 times a week some days. I get pretty busy. I had to get up at I don't know what hour to get here this morning. I did not exercise today. I'm hoping to do it tomorrow. So if I could get 3 times a week, it's good. If you could get your patients to buy into that, that's great. We have to think about how to make it real and realistic and get them to do it on a regular basis. And that is it. I thank you very much.
I'll wait for the din here. So, it's my joy and honor to introduce our final keynote speaker here today, Candace Powell. Candace is a colleague and friend. She is a nurse and hospice and palliative care leader and a human rights activist for the dying and the bereaved. Since 1992, Candace has served as the executive director of the Maine Hospice Council and Center for End-of-Life Care. As director of the council, as well as through Maine's Pain Initiative, she has made it her mission to develop partnerships and programs to educate and mentor those serving people at end of life, and especially those who work with the underserved and invisible, including veterans, the homeless, and prisoners. Candace's passionate reach extends beyond Maine. She is nationally recognized speaker and member of the National Hospice and Palliative Care Organization, where she serves on their steering committee and leads their ethics committee. And indeed, I learned this morning that Candace was instrumental in developing the first hospice veteran partnership in the country. She also served on the Alliance of State and Pain Initiatives Advisory Board and co-chairs the National Veterans Advisory Council. And last night I learned that she's an avid rower. So if we just had to talk about exercise, thanks for setting that bar, Candace. This morning and later today, Candace will bring insights to the existential experience of pain, a journey many of our guests here today live daily, a journey which health professionals, families, friends, policymakers, and communities need to better understand in order to achieve optimal, more compassionate care. Let's welcome Candace Powell to the stage.
Good morning, everyone. It's a privilege to be here today and to see so many people who are so interested in the pain movement and doing what you can do. I'm going to really ask you to take a big leap of faith with me this morning and to really change gears and switch from one side of your brain to the other. Because what we're going to be talking about is about all of us in this room. For 30 years, I've spent my life in the field of end-of-life care, and one of the things that has been so apparent to me is that we are incredibly complex individuals. I think of Walt Whitman and what he wrote in Song of Myself, and he said, "I am large, I contain multitudes." And when I think of the area of pain management, what I think about is how complex we are as human beings. And when I look at everybody in this room, I say to myself, how absolutely amazing if we could all work together to address some of the complexities of our lives as human beings. And when I work with the underserved, like prisoners, veterans, homeless veterans, refugees, and others who barely have anyone who is willing to listen to them, much less address their issues, it just is overwhelming to me sometimes. In hospice and palliative care, we have dealt with existential issues. We deal with them all the time. Most of us as human beings live with existential concerns. The meaning of life, guilt from what we didn't do, identity crises, and very, just across the spectrum of issues that are really considered existential concerns. When I work with individual populations, like prisoners, I teach at the Maine State Prison. I've taught there for 12 years and started a hospice program there 12 years ago. When I work with these folks and I listen to them, and there's a phrase called confiding relationships. Confiding relationships are relationships that many of us seek to find, some of us do find, some of us hope to find. It's that person, that individual in our lives who we can tell anything to, will not judge us, will unconditionally care about us, no matter what we say to them. And when we're dealing with existential issues, which, by the way, not all existential issues and concerns translate, as you know, into existential suffering. But when I witness and bear witness and listen to what I identify as existential suffering and the impact that it has on our ability to either manage pain effectively or not manage pain at all, then I say to myself, where are we going wrong as we approach pain and symptom management with folks at end of life? And one of the things I come up with, because I don't think it's worth wasting any energy at all to beat ourselves up because of what we don't do, what we need to do is just realize that the greatest resource we have is right here inside ourselves. We have a lot of tools, very effective tools at assessment, but one of the greatest tools that we have, if we're in touch with it, is our ability to listen carefully to another human being. Not what they say necessarily, although of course that's important, but what they don't say. How carefully can we listen? And if each one of us in this room would say to ourselves, what if that were me? What if that were me going to the doctor, sitting down with my physical therapist? What would I want them to do? How carefully would I want them to listen to what I have to say? I'm going to tell you 3 stories. I love to tell stories. And someone who is a confiding partner or serves that role as a confiding relationship, that person will encourage us to tell our stories. A colleague of mine said, until one of his patients made him sit down and listen to what he had to say, did he realize that storytelling is a huge component of assessment. And he said, when that particular gentleman said, Doc, you sit right there and you listen to me. You're always in such a hurry. Please listen to me. And my friend said, at that moment, he realized that he needed to incorporate storytelling into his assessment, because then and only then did he understand the protocol that he needed to discuss with his patient and why his treatment plan prior had not been effective. I'm going to tell you a story about Doris, and these names are not real, they're fictitious. I received a call from a colleague of mine years ago, and he said to me, he said, you know, I have a patient, and he said she is really, she's presenting with pain. I can't seem to find the etiology. Don't know what's wrong with her. She seems to have multiple issues. she seems to not want to live anymore. She wants to take her own life. He said, I'm beside myself. I've sent her to psychologists, psychiatrists, everybody. He said, and nothing seems to change her mind. He said, I just happened to think about you and wondered if you might just take a few minutes to meet her and talk to her. And I said, well, does she want to talk to me? Because we know how well that works, don't we? And he said, well, I don't really care. He said, I really want you to talk to her. So I met her, and of course she didn't want anything to do with me. I knew that right away. So I gave her my card, and I said, if you should want to talk, give me a call. You can reach me at this number. Her son had just died suddenly, and her husband was dying of cancer at the time. And so a few weeks went by, and then one day I got a call, and it was this lady. I recognized her voice. She asked me to come over, and we wound up working together for about 3 years. I'd visit her a couple times a week in her home, and she was dealing with a lot of issues and a lot of, as I said, presentation of pain. But as I listened to her, and at times she would go vacillate from screaming at me to just talking in a quiet voice. She was very feisty, very bright. And our relationship, as I say, spanned about 3 years. She didn't take her own life. She told me a lot about her life. I spent hours listening to her. Our professional relationship ended. She had an incredible network of support. She didn't go see the doctor as often because her pain presentation was not as acute and as chronic, both. So about 3 or 4 years after that, I got a call from her family. I was on vacation. They asked me if I could come and meet with her. She was dying of congestive heart failure, and she wanted to see me after all these years. I said, sure, and I went to talk to her, spent some time with her. Her family was concerned that she had not died clinically. All clinical signs pointed to an imminent death, and she just was lingering. And we know that happens a lot. And sometimes it happens when someone is dealing with existential issues. We don't know what they are. And so I said to her, is there something that is preventing you from letting go? And she said to me, what in the world are you talking about? And she, with very little energy, was able to be as feisty as ever. And I said, well, just it's something to think about. Your family is concerned. Just think about it. She closed her eyes, which was an indication it was time for me to go. So I left, went back to resume my vacation, and got a call in 2 days. The family apologized and said they couldn't believe they were asking me this, but could I come back to the hospital? Their mom had something she wanted to tell me. So I went back to the hospital, and I was sitting there beside the bed. She had her eyes closed. I held her hand, just announced that I was there, said she didn't have to say anything if she didn't want to. She opened her eyes and she said, I have something to tell you. And once she told me what she had to say, I understood why she was still alive. And she said, now you know what you're going to do with that information, don't you? I said, yep, tuck it away with everything else. And she smiled and closed her eyes. Then she opened her eyes again and she said, I have one more thing I want to share with you. And I said, what's that? And she said, you know, all those times I went to the doctor, all those times, you knew I didn't want to die, didn't you? And I said, no, I couldn't take credit for that, and neither can anyone else. I said, but we did sense there was a reason that you wanted to live. And she looked at me and she said, it wasn't dying I really wanted to do at all. It was living with pain that I just did not know how to do. And I find this is true for all of the folks that I work with who are dealing with existential issues. The pain of living is far more difficult. We find it very difficult to assess this. Very difficult. Our system doesn't support storytelling. It doesn't reimburse for the hours that it takes to really learn about somebody's life. I'm going to tell you another story. As I say, I've taught at the prison, the Maine State Prison, for 12 years. And I work with a wonderful group of inmates. I've come to know them, come to care about them a great deal. And one day, the men have started a band. And we were sitting at band practice one day because they play a lot of beautiful music for our conferences. And one of the young men, new in the class, kind of despondent, never smiled, always looked down. I was sitting next to him. And I said, "Do you enjoy music?" And he shook his head, yes. And I said, "What kind of music do you like?" He's a young man, he's only 26. And he said, didn't say anything for a couple seconds, then he said, "Heavy metal." And I said, "Oh," I said, "heavy metal." I said, "Yeah, I remember it was about the time my daughter was in high school and college." I said, "Sometimes those lyrics reflect a lot of anger." I said, "Is that why you liked it?" And he shook his head, yes. And I said, "Do you have a lot of anger? You have it stuffed in there somewhere?" He didn't say anything again for a couple seconds. And then he looked at me and he said, all he said was from 5 to 14. And I was listening carefully and I said, "Were you abused from the ages of 5 to 14? And he shook his head, yes. I said, "You know, as a mother, myself, I wish I could just reach right down inside there and take that pain away from you." And the band resumed playing and we went back to class. And the next day, the next time we had class, when I left class, there was this tiny little note folded up on my books. And I opened the note and it simply said, "Remember when you said you wish you could take our pain away? Well, I want you to know that you already have." I'm going to tell you another story, and this is about a veteran. I was on a panel with Vietnam veterans, and it was a compelling testimony that one of them did, and I thanked him for his wonderful, articulate testimony. And afterwards, he asked me if he could speak with me for a couple minutes. And we went out in the corridor, and he put his hands on my shoulders, and he looked at me, and the tears started running down his face. And he said to me simply, "Who is going to forgive me before I die? I've done some things I wish I hadn't done. I was told to do them, and I did them. Who is going to forgive me?" And the two of us just stood there, and the tears were just running down his face. So I say to you, ladies and gentlemen, we need to really pay attention to not the visible wounds, the invisible wounds, because it will help us go a long way to addressing the comprehensive nature of the complicated issues around pain management. Thank you very much.
Thank you, Candace. That was beautiful. So if you're following along with your schedule on the table, you'll see that we're 10 minutes ahead of time. So you have 20 minutes at this time to take a quick break.
So good morning again. I'd like everybody to please take your seats. We're going to get started with the next part of the program. Before I do so, I want to make a couple quick acknowledgments of some special groups that have made this day possible. One is the library staff that has put together an amazing collection of resources that extend beyond today. You can see some of that display on the front entrance here and in the brochures that have been put together. These are available on our website as well, with a lot of other electronic resources for everybody as members of the community at the University of New England. I'm going to take a moment now to ask a couple or three special students to come up here to introduce a video that you're going to see in its entirety now. You might have seen the teaser, which was a 2-minute video, and the full 10-minute version is very powerful. So I'd like to have Lindsay St. Louis, Kristen Brusky, and Mike DePice come up here. Lindsay's going to say a few words to introduce the video, and then we're going to roll it. We are simultaneously pushing this over to our other auditorium where our first-year pharmacy and first-year medical students are. We do practice what we preach. We gave them some exercise today to walk over across Route 9. So without further ado, Lindsay St. Louis and the team that put the video together.
Hello, I'm a senior neuroscience major at UNE, and Kristen is a medical student, and Mike DePice graduated last year, and we've been working on a project with pain patients in the community, and it's been great. We're really enjoying it, and we hope you enjoy the video. And for those of you that come to our breakout session, Community and Pain, you'll get to see our case reports and narratives that we also made for the 5 people that we interviewed. So thank you all, and thanks to all of the people who have been working with us on the project.
Chronic pain, a complex disease that can be described as an ongoing or recurrent pain that does not go away after 3 months. While there are many different forms and causes of chronic pain, each patient's condition is unique, making diagnosis and treatment challenging for physicians and healthcare professionals. The following individuals, although diverse in their medical conditions and pain states, are united in their willingness to share their experiences, hoping to raise awareness of the complex emotional and physical tolls that accompany living a life in pain.
Through the years, my job has always been working with my hands. I went to high school and then the Army and then became a plumber, and at work I was working in a confined space too long, and I went to stand up and I couldn't stand up straight, and ended up going to the doctor after, and they found out it was a herniated disc. So from there I had one back surgery where they took part of the disc out, and it was good for a year. I went back to work, and sitting on my toolbox I went to get up, my leg gave out. Went back to the doctor and they said a disc fragment broke off, you need another surgery. They said we have to do a fusion, and they put the rods and screws in. They took some more x-rays, like 6 months, 8 months, and then a year. The fusion didn't take. Your screws are moving in your vertebrae. I think it was 2001 was the last surgery. I woke up with a brace around my waist. I said, what's that for? And they said, well, that's temporary. We want to make sure that it's going to have time to fuse. I still wear the brace to this day. I never got back to work after that because I didn't recover. So I wear a $2,000 brace to be able to stand or sit.
I was involved in a car accident. Initially, I'm a nurse and I worked at UNE. I fractured C4, 5, and 6. I was 6 months in the hospital. The OT and PT and nursing were right there, to help me all the way through. The worst part, actually, is that I can't feel from my breast down. And I have some movement of this arm and hand. This one, very, very limited, and this is where most of my pain is. especially when I have spasms. And I've had it since my accident.
Years with the SEAL teams were a training like no other. Pain was something we learned to deal with. It doesn't matter how painful it gets. The injuries stacked up on one another comes with the territory. It's just they're just injuries, and I dismissed them. Both my shoulders, my base of my spine is fractured. I've got 5 herniated discs. I've been opened up surgically about 5 or 6 times in the abdomen. My right and left Achilles have been severed. Everything's is all banged up and destroyed. This part's okay. And then PTSD sits. The PTSD has an association with this chronic pain like I never realized before. I never would give it to someone, but if you could give it to someone and take it back, I think the person would be like changed forever, and they would have a perspective on the disease or whatever it is that like never before, like no medical journal could give them.
Each chronic pain patient requires a treatment plan that is specialized to their own specific needs, one that focuses on reaching the person's individual goals and improving their overall function and quality of life. Sometimes relieving the physical pain is not enough. A specialized care plan must address both the physiological and psychological components associated with chronic pain. By listening to a patient, a healthcare provider can create an environment that facilitates a healthy partnership, encouraging patients to become proactive in their own care.
The first doctor I was with, I knew right away that he was just going to hand me the prescriptions. And I said, is there another avenue for me, another way to go? It was not giving me the incentive to want to help myself because I just felt like an example or a study or just somebody that they don't know anything about, you know? And I wanted to be known. I wanted someone who knew what they were doing and knew what they were talking about, that had compassion. Because I went through all of that, it made me become my own advocate, where I started to use the computer and I researched a lot of things. You make your own road, your own map, because you don't have a doctor sitting in front of you 24/7, 365. I also obtained my notes from my doctor, my file, and I went through all of the verbiage. I looked it up if I didn't understand the terminology. But basically, my DO, the hands-on, was the best thing that ever happened to me, so I really didn't need to go elsewhere. He straightens you out, and he explained to me that your body has memory, and because my body has been in this state for so long until I did something about it, we have to readjust it and we have to bring it back to a state of normalcy. Asking people for help all the time, it was overwhelming for me. It crushed me. And you start to feel a lot of guilt, thinking that they really don't think that you're hurting as much as you are, but you really are, and you don't want to complain all the time. The emotional part of you is a huge issue with this disease. I feel it. I know it. You don't really feel balanced, and you do get depressed. So as long as you understand that that's happening to you, you can work properly with it. It's the strong mind, and I think the body's just taking the punches now.
I think as a chronic pain person, we kind of educate ourselves about the medical field. I try to stay positive about it, but there's so much negativity, so many things falling in the cracks. And if we don't stay proactive and right on top of it, you know, it'll take longer to get the right care. It's hard to explain it to some people that don't have chronic pain. It's almost like the chronic pain person feels guilty if we're good that day, because we feel like the doctor's not going to see the real us, the real me in pain.
I was just so thankful to get a name and to have a doctor who understood that yes, I was in pain, no, I was not faking. I don't want attention, I just am in pain. That's what mattered when I first got the diagnosis. I had a doctor and he said there are treatments, and I have a doctor that believes me.
By that time, the pain had gotten so bad that I was thinking I had bone cancer. That's the only thing I could think of, and I was praying that my only hope was that I could live to see my son graduate from high school. And I continued to talk to my doctor, but I didn't have the words, and I'm a writer. I'm a communications person, and I couldn't communicate to him how bad that pain was. And I can remember him telling me later, as soon as I walked in the door, he knew I had RA. And I can remember riding home and crying along the way. Finally, someone had maybe diagnosed what I had. He treated me as an equal. I knew my body better than anyone else, better than he did. He was an expert in rheumatology, in the drugs that would help me, in my body symptoms, but I knew my body, and he acknowledged that and encouraged me to act as his partner. And he is my hero, my savior. I love him to death.
I reach out to other resources besides people, and social workers and doctors that say chronic pain is something they don't want to talk about or they don't deal with. I work with horses. I feel the horse, and that horse feels me when I'm working with that horse. And I found nothing like it in my life. When I'm done about 3 hours with the horses, I'm good to go for the rest of the day.
My family is the best, and I'm very, very fortunate to have the husband I have, and the children I have, and the grandchildren I have. It was very hard on all of them, and it was especially hard on Mike. And that's all I've had over here is love. I mean, all my extended family and my friends. And under my spinal cord injury, there's a person, and a person that wants to express herself, you know, and be a meaningful member of the community.
Chronic pain patients need support from their surroundings. Healthcare professionals that listen and accommodate are likely to come up with creative solutions. By being engaged in their own recovery, patients can maintain the optimistic outlook that is necessary for effective treatment. Communication, understanding, and provider empathy can have enormous positive impacts on the people who suffer from chronic pain.
The truth is, we may never be pain-free. We don't want to lose hope, but we need to live our life. This is our life. Every day that goes by is another day of our life that we have used up. And we can still live a very worthwhile, rewarding life, even if we do have pain.
Pain is inevitable, suffering is an option. And I say that you can still have a fulfilled life with chronic pain. You just got to be more creative and adjust your life to your condition.
You know, looking out, I was watching the audience as this video played, and most of you were just completely transfixed, and it made me appreciate something special about the University of New England. Not only can we bring in great speakers that are experts in changing pain education in the United States and Canada and the world, we also are engaging our community. Many of the patients and people you saw featured in that video are here with us today and participating fully with it. And I think the other very special thing is this interprofessional initiative is so student-centered, and it's students that are driving a lot of this, the creation of content like this video, or putting together these cases, or serving on the planning committee for the team that has been part of the symposium. And again, that is so special to the University of New England, and it's truly interprofessional. So thank all of you for participating. I get to be lucky in that I'm a contact person for the Center of Excellence in Neuroscience, and many times people from the community do email me because of something that one of our faculty or students accomplished. And I received such an email on August 24th. I dug this back up through my archives in preparation for today. That email was from a woman from Canada who had a daughter who had terrible pain. And she said in the email, "Sirs, I understand that the University of New England is a center for study of chronic pain, and I'm wondering if you are working towards a cure for complex regional pain syndrome and reflex sympathetic dystrophy." She goes on to say, "My daughter is 24. She sprained her ankle when she was 13. Misdiagnosis and medical mismanagement allowed this disease to set in. If and when you find a breakthrough to end this terrible condition, I would love to hear about it. Anything we can take to her pain management doctor would be great. Thank you very much, and best wishes for good research. Judy Hershevitz." I responded almost immediately, and I think my life has become enriched by briefly meeting this family for the first time in person last night at dinner. In my response, I said, "I'm willing to talk further with you and your daughter. One possibility is having you share this story with our medical and health professional students. We want to make sure patients and their families have a voice on how pain impacts them and what we need to do to better in preventing and treating chronic pain." Again, that started the nucleus for today's Spring Symposium. So with that, I'd like to introduce a very special young woman. Paula Oran is from Winnipeg, Canada, and she will tell her story in the narrative. I can tell you she took extraordinary efforts to get here to be with us today, along with her two parents, Mel and Judy. So please welcome Paula. She's going to sit while she delivers this. The camera will be focused on her. And at the end, we'll convene a panel that will invite back our keynote speakers to join the family and be moderated by Kim Block. So welcome, Paula.
Hi. Today I'm here to give the patient's perspective of living in chronic pain. My name is Paula Oran, and I have complex regional pain syndrome, also known as reflex sympathetic dystrophy. As a result of a twisted ankle, my right lower leg from the knee down has been in pain. I'm 25 years old, and I have been in constant severe pain since I was 13. Sorry, I'm a little nervous. 1,000 people looks very large from up here. I think the biggest change in mentality for healthcare professionals when working with chronic pain patients is making the leap from "this is a difficult patient" to "this is a patient with a difficult condition." We are not the problem. Our disease is the problem. One of the biggest hurdles we have is obtaining pain medication when we need it. I start here because when you are in unrelenting pain, access to painkillers is a major concern. Opiates are some of the most useful drugs for treating severe pain and the most challenged. Governments legislate on the basis of protecting people from addiction, but in the process they lump chronic pain patients in and force us to follow strict guidelines about access to medications. In fact, only a very small percentage of chronic pain patients become addicts, and the majority of that small percentage had a history of addiction. Doctors need to be cautious with opiates, but the fear of addiction must not compromise the quality of care given to patients. Doctors must understand the difference between addiction and physical dependence. In the same way, patients must not be afraid to tell their doctors about their reaction to medications for fear of being blacklisted or cut off. I bring all of this up because when you are a chronic pain patient, this is the stigma. I highly encourage patients to ask their pain doctors for a letter certifying they have a legitimate condition and what drugs are being used to treat it. This is essential if you have to go to the ER with a massive pain flare-up that has left you incoherent. From a doctor's point of view, it's easy to see a patient for an appointment, then go on to the next patient a few minutes later. It's easy to go on to the next person while the patient goes home and is still struggling with their problem. The problem never goes away for us. We're in the doctor's lives for a few minutes at a time, once every few months. But this is our life. It never goes away. Every single second, I am in pain. From my knee down to my toes, on my right leg, all there is pain. The pain changes and moves, and different parts hurt more than others at different times, but there is always solid pain from my knee down. On top of that pain, I have other kinds, all different forms. Stabbing, shooting, burning, visceral, aching, throbbing, whatever adjective has ever been used to describe it, I've felt. On my good days, I'll be at maybe 5.5 out of 10. My worst has been about 9.5 out of 10. I average around 6 to 8 out of 10 on a pain scale. This is with all of my medications. Complex regional pain syndrome, or CRIPS, is considered one of the most painful conditions around. The McGill Pain Scale lists CRIPS as more painful than unmedicated childbirth and non-fatal cancer. Only fatal cancer rates is more painful. Everything I do makes the pain worse. Moving, putting pressure on it, having anything touch it, no matter how light, everything makes it hurt more, on top of the pain I always have. I say this not because I want people to feel sorry for me, but for you to understand the extremity of my condition. The fact that everything affects my pain makes life even more difficult. Getting dressed is painful because the sock puts pressure on my foot, my jeans brush my skin when I pull them on, and then they squeeze my leg all the way around. A million things no one ever thinks of hurt me, from the single dog hair that lands on my leg to an air pressure change in an elevator. I've had to make numerous adjustments from my environment just to make things as comfortable as possible for me, and if any of you would be interested in hearing about them, please ask me at the end of this speech. Even with them, life is very difficult. The pain turns even simple things into massive ordeals. Remember that for most of your patients, it was a long and painful road to get to you. No pun intended. Thank them for coming in. Try and be polite and kind. Most will have had doctors question their pain, disregard it, and they'll have seen so many people, so many healthcare professionals in the process of trying to get a diagnosis. Take a second to realize that. Until only very recently, pain was considered a symptom of a disease, not a disease in itself. This is a highly significant change in the way pain conditions are being viewed. Instead of taking months or years trying to find the cause with little or no help in the meantime, the pain is being tackled as the main issue. For example, if a patient comes into the ER in Winnipeg, my city, reporting pain that's disproportionate to the injury and of a long duration, they are now sent to the pain clinic within 24 hours. This is a huge sea change in how pain is being treated. If this had been around when I was first injured, I wouldn't have had 18 months of misdiagnosis, mistreatment, and circular referrals that allowed the CRIPS to fully set in. New studies show that if given treatment in early months, a cure is possible. I never had that chance. Many patients will cancel or reschedule their appointments. Please try and not be upset with no-shows. Patients don't want to miss appointments, especially when they're in a lot of pain and need their doctors most. Maybe they were sick all night from their medications, or maybe they were in so much pain they couldn't even manage to call you. Sometimes you're just in no condition to manage to get up and go anywhere, and I've had to schedule so many appointments over the years I can't even tell you. Please remember this, and don't blacklist them. To make things easier, my doctors schedule me in the late afternoon when I'm at my best. Try and work with your patients and try in making these appointments. My family doctor and my therapist schedule me at the end of their days, so if I do have to cancel, it's not a big problem for them. My family doctor sees me once a month. I save all of my concerns up and I bring them to her. She's not my pain doctor who's so busy I only see him every few months, but it makes me feel as though my medical concerns are being taken care of and are listened to. One of the biggest things I can suggest for patients is they keep a list of their concerns as they develop. That way, when they do get to the doctor, they don't forget anything, and even if you're not able to speak coherently during your appointment, the doctor still knows what you wanted to talk about. Memory is also affected by pain, so I write things down as soon as I think of them. I recommend writing down everything important the doctor says for the same reasons. At home, I keep a daily journal noting how much pain I've been in and when I've taken painkillers for breakthrough pain. I note any unusual symptoms in my general condition for the day. This is very important for two reasons. First, by writing the time I take painkillers, I ensure I don't overdose myself, and secondly, I can look back and see how well I've been doing with my medications and therapies. I can just search my files and find out that since a new drug kicked in, I've been doing better or worse on average. Doctors need to understand that with as much medical knowledge as they have, the patient knows their condition better. This is our lived experience. The doctors might have the technical knowledge, but we have the daily reality of living with a disease. Listening to the patient and thinking outside of the box when the standard procedures aren't working are essential for any complicated case. You can't just say, well, this is the way we've always done it, and then leave it at that, when the way you always do it just is not working. One of the most difficult to treat issues I have is the development of skin lesions and the loss of my toenails. My wounds are very difficult to treat. Initially, some doctors accused me of scratching and picking at my skin. Skin lesions didn't immediately fit the doctor's pre-existing knowledge of the disease, so the automatic assumption was that I was at fault. I go to a monthly wound clinic where the nurses are used to seeing all sorts of chronic wounds that don't heal well, from terrible burns to the complications of diabetes. Sorry. I've tried all of the products they have that might help me. My skin, when you follow the normal procedures of keeping the wound moist, just kind of gets wet and mushy and then just wipes right off. The wounds, however, get dry and bleed. The only way to treat me is through trial and error, trying all sorts of dressings and prescription lotions and creams. The only adhesive tape I can actually use is ostomy tape. If the nurses at the clinic or my dermatologist were only working with the standard arsenal of wound care, I would be in much worse shape. Being open to suggestion and listening to the patient when they say something isn't working is the only way to deal with patients. Otherwise, you just add to their problems. When I have a flare-up of increased pain, the lesions show up consistently within the next day or two. The lesions start out looking like small red dots or a thin red line, but they quickly get bigger, open up, and bleed, causing even more pain. The lesions last for a week and they heal very poorly. At this point, my skin is actually so dry and fragile that the normal bacterial flora that exists has started to cause even more problems with my skin, my fingernails, and even my scalp. And even though these issues are easily resolved by my dermatologist, it leaves a massive toll on my self-image. It was kind of difficult not to add in a line defending my appearance. I know that as doctors, you're keenly aware of the limits modern medicine has, or if you're students, you quickly will. One of the worst feelings I've had as a patient is knowing that I'm at the limits of medicine for crips, or that's the way at least my doctor has made it sound, but I'm happy to say that talking to some people in the conference, they've suggested some new things, so I'm quite happy. And I do appreciate that, by the way, and I want to thank you all. It's really felt like that I'm just looking for the next study or the next paper that could help me, and everything that has been mentioned normally for my condition I've either experienced or had ruled out by my doctors for one reason or another. The last few things I've tried have come from new research we found online. I know how dissatisfying it must be to see a patient coming back to your office every few months in as much pain or more as they ever were, but you cannot let this affect how you treat the patient. That irritation cannot lead you to distance yourself from the patient or get upset with them. As frustrating as it is, remember, the patient is even more frustrated. It's not the fault of the patient for having the disease. It is tough to deal with chronic pain patients. We can be emotional and angry and even lash out at our doctors. Legal, pharmacological, or medical reasons can prevent the doctor from giving the patient the amount or kind of medication the patient feels they require. Instead of acting defensively or dismissing the patient, though, try and remember that they are not mad at you personally. Sympathize with them. Legitimize their concerns. Please don't send them away or refuse to see them again. No one goes into medicine to deal with patients they can't fix. Despite a patient's and a doctor's best interest, chronic pain is frustrating and emotionally burdensome to deal with, day in and day out. It's essential the burden is not taken out on the patient. It's hard to see something you prescribed hurt the patient because of unintended side effects. One prescription can turn your life upside down. I was a student at the University of Winnipeg, and I was very happy there. Unfortunately, my pain got to a point that my doctor prescribed oral ketamine for me. Ketamine is used to stop the memory of the pain, but has many side effects. All of my higher thinking processes were shut down. My memory got so bad I forgot words in nearly every single sentence. My mind was in this complete fog and my body was no better. I gained 60 pounds in a single year as I was dieting. My emotions were completely out of control and my stomach turned upside down as well. There was no choice for me but to drop out of university. My doctor looked into other drugs and found an Alzheimer's treatment, memantine. Memantine still compromises my ability to go to school, but at least I could have a conversation without wanting to break down and cry from confusion. However, the mental deficits are still enough to bother me on a very regular basis. I tend to remember things only for briefer periods, so I have to write things down. I've always really enjoyed going to school and learning. You can understand that having to choose treating my pain over my education was personally devastating. When I was 13 and first hurt my ankle and the pain wouldn't go away, the pediatrician thought I was exaggerating or acting out. His perception of me as an overachieving perfectionist warrior blocked him from seeing the extremity of my pain. Perception is absolutely everything sometimes. It took 18 months for a proper diagnosis, and by that time, Crips had fully set in. I credit the pain clinics at the Health Science Center and the Pan Am Clinic, both in Winnipeg, and my pain specialist, Dr. Jeff Dewar, and his team at both clinics for rescuing me. That's really what it felt like, rescuing me. One of the best medications they've prescribed for me is Nabilone, and which I still take every single day. Nabilone's active ingredient is THC, and it stopped the pain spasms in my leg that developed every time something touched it. Nabilone enabled me to get off the crutches I'd had to use for 4 years. I also owe more than I can say to the physiotherapists at the Children's Hospital in Winnipeg. It was a physiotherapist who first suspected Crips long before our doctor did. Even today, after 12 years of treatment and the best pharmacological regime I've found yet, I'm not independent. Far too many days are spent in bed dealing with massive flare-ups of pain. I just lie in bed and scream. My wounds open up and I bleed. Even with the memantine, though its side effects are less than those of the ketamine, I don't feel sufficiently competent to return to school. One thing that I haven't touched on until now is the emotional aspect of being a chronic pain patient. Just being in pain is bad enough, but then there are the effects of being isolated from society, from significantly downgrading your plans for life, and from not being understood. Lack of understanding from the medical professional side can be devastating. One thing in particular that really got to me was learning my condition isn't just in the peripheral nerves in the affected area or the nerve cluster in my spine, but in how my brain receives and transmits pain signals. I'd always been told for so many years that the pain was just in my head. When I learned it literally was, that was emotionally crippling. I went into this emotional tailspin. I'd always believed that my brain had been mine, even that it had been me trapped in a failing body, but me nonetheless. To find out that my pain was so deeply rooted inside my brain was a shock. More than a shock, it felt like a betrayal. The seed of what I thought I am, that had promised me this bright future based on my mental acuity, was what tore the future away from me. Only after a lot of thought and cognitive behavioral therapy was I able to get a handle on these types of thoughts. This is a very important point to mention. Without therapy, I would not be here speaking in front of you today. I wouldn't be talking honestly about how the pain has affected me emotionally for sure. Therapy allowed me to get a grip on all the negative thought processes that develop from being in this much pain for this long. I think a lot of patients are reluctant to try psychological therapy. One of the leading causes of death in Crips patients is suicide. The mental aspect of being a chronic pain patient is essential to deal with, despite how difficult it is as a patient to recognize it. Only once I had a bit of a breakdown did I finally admit to myself that I needed real psychological support. Learning to examine my emotions and thoughts has given me a really large difference in my life. It took a year of therapy, but I was able to feel as though I had some control over the conscious part of my mind. Therapy gave me an element of control, something I didn't have over the rest of my body. Only then did I gain some more confidence. I wish all of my secondary issues to the Crips had such easily accessed treatments. When it comes to the main complication that's developed because of the pain, I fall in a crack in the medical system. The problem, which I touched on earlier, is that I develop skin lesions. My pain doctor can't treat the sores, and my dermatologist can't cure them because it's not a skin disease. I'm stuck in an odd space between two specialties, and neither doctor can do enough to help me. Needless to say, I have a number of different medical issues, and while they're all interrelated, there's no one doctor able to treat all of them. Despite the frustration of needing so many different specialists to help look after me, I can take a lot of comfort in knowing I have the best care I can. I have world-class care. I've been to the Mayo Clinic and been told there's nothing more that they could do for me that my doctors at home are not already doing. And I know I have a lot of personal benefits. I've been working on graded motor imagery and mirror therapy with my physiotherapist, and I believe it holds a lot of promise for the treatment of Crips. It is also one of the easiest, least painful, least expensive treatments I've heard of, and it comes from a very new and exciting way of looking at the disease. I've also had access to a wealth of professionals to treat specific side effects of being in so much pain, from registered massage therapist to a sleep specialist when the pain began to cause very bad insomnia. I've been exceedingly lucky in my treatment. I'm also constantly looking for new research, and I have sometimes been the first patient from my particular pain clinic to access new therapies or drugs. I live with a very supportive family, with a mother who's a full-time caregiver and a caring father. I have a best friend who is literally a doctor as of next month, and a very supportive boyfriend. I have all of the advantages the patient could ever want, and I'm still here, and I'm still in too much pain to do anything, to do so many things. With active, involved friends, family, and doctors, I have every advantage going for me, including socialized medicine, and I'm still in this much pain. I live at home, I can't go to school, I can't work, and I can't drive. The prospect of being 25, living at home with no real likelihood of a job or independence, and it sometimes feels like even real happiness, can consume your life. At least I live in Canada, where I don't have to worry about the economic aspect of it, but your patients don't have that comfort. It's difficult knowing that if this is as bad as it is for me, then for all other patients who don't have the supports and resources I have in place, it must be even harder. You can understand where some emotional turmoil comes in. That said, one thing that has helped and that is really helping is starting to look into ways to make some constructive use of my experiences. In the last year, I've started thinking about disability advocacy. I'm looking into volunteering in a position where I can share my experiences and in some way feel as though out of all this pain some good might come. I'm very pleased to have had the opportunity to come here today to share my story as a chronic pain patient with the next generation of healthcare professionals. In particular, I really want to thank Dr. Bilski and his team for inviting me and giving my parents the opportunity to be here with me today. I also very much want to thank the university for putting on this conference. I think it's really wonderful that students of so many specialties are interested in helping chronic pain patients. I hope what I have said here today might give you some insight in what it's actually like to be one. I would like to think that all of this might help someone else. I'm standing in a room full of, sitting. I was planning on standing. In a room full of healthcare professionals, and if anyone has any ideas for me, please come talk to me or my parents. Anything I can bring back to my doctors would be wonderful. And thank you so much.
Do I go?
I know I share tremendous respect for you, and I was reading, Paula, thank you so much for being here. I was reading in the write-up earlier this morning about Paula that she was one of the torch bearers for the Vancouver 2010 Olympics. You're still carrying a torch, and you're carrying a bright torch for all of us, so thank you so much. I'm Dr. Dora Ann Mills. I'm the Vice President for Clinical Affairs here at UNE, as well as the Director of Public Health Programs. I'm also a pediatrician, and I was very appreciative that you brought up the pediatric aspects of pain, because I also feel that the pediatric aspects of pain are very much, have a complexity that's different than adult pain, so thank you. I'm here to introduce our MC for our panel, and I'd like to invite all the keynote speakers from this morning as I'm speaking and introducing people to come up and take a seat here so that we don't spend a lot of time getting people seated. I am thrilled today that a good friend of mine is here to MC our panel, and just before I quickly introduce her, I want to make sure people realize, our students and faculty, that this will be an interactive panel, and you're invited to ask questions of our panel. There are 3 microphones in this gym, and also in the Campus Center Gymnasium, there are also microphones set up, and they'll also be able to ask questions. I'm not sure how that is, but I'm assured that that's going to be able to be happening. Our MC for this panel is, where is Kim? She's coming up. Just a minute. Kim Block is a dear friend, and I'm so grateful that she's here to join us today to MC this panel. Kim Block has been an news anchor for a CBS affiliate in the southern half of Maine, WGME, for 31 years. I think she must have started as a young teenager, but many of us have seen her over the years deliver us difficult news, happy news, and she's also had a specialty in reporting on medical and health news. She has won Emmy Awards particularly for her stories where she's gone to Iraq and China and reported back to us here in Maine about events happening there and children who were brought over from those countries to be treated here in Maine for their health issues. She is also very well known to many of us for her community service. She has raised money tirelessly over the years for countless organizations. She has spent, for instance, many Memorial Day weekends and Labor Day weekends on TV raising money for the Barbara Bush Children's Hospital and for a Muscular Dystrophy Association, as well as a number of organizations like the Maine Cancer Foundation and others. She has been awarded several times for her tremendous work to our community here in Maine, including from the University of New England, the Deborah Morton Society Award. So she also is here today. I invited her to come share and MC this event with us because she also lives with chronic pain. You've shared that publicly a few times, but she doesn't, not often talks about it publicly, and you would never know it as she is anchoring the news and raising funds for so many other causes. So I always have had a tremendous respect for all of the work she does, and especially knowing that she lives with chronic pain. She also is the mother of 2 wonderful teenage children, and she shares the stories about her motherhood with us as well over the years. So thank you very much, Kim, for joining us today, and please join me in welcoming Kim Block to you.
Thank you so much, Dora. I know we're short on time. You could have cut that intro by 30, 40 seconds, and I would have been less embarrassed. But thank you. It is wonderful to be here today on many different levels, as Dora said. As a medical health reporter, I am thrilled that this issue of chronic pain is, taking center stage here at UNE. I am so excited that the future doctors, physicians, pharmacists, healthcare workers who are in this room are going to gain some insight and perspective by what we're hearing today. I'm very, very thrilled about patients like Paula who are willing to tell their stories, and to the professionals here on our panel who are working in this field. I don't think I even realized there were people like this out there working in this field, and it is really gratifying when you are a patient with chronic pain. I have shared several times over the years that I was diagnosed with fibromyalgia a number of years ago. And even to this day, I think we know that's a bit of a puzzling illness for people, especially for doctors. And I have gone from one to another to another. And I think many of them were reluctant to put a name on it. They refer to it as kind of an umbrella term for a pain disorder, pain/sleep disorder. But I will tell you that when you are a patient like this and when you are suffering, the diagnosis is important, because all you want is to understand that there is something that you can wrap your head around so that you can begin to move forward. And in living with chronic pain, a good deal of it is a patient's responsibility, no doubt. You must learn to accept a certain level of pain in your life. Sometimes I kind of have to laugh when I see what people call in sick for at work, and I think, are you kidding me? But you understand that that's just part of your life, and unless you want to sit up on a couch and curl up for the rest of your life, you're going to find a way to move forward with it. And it takes a number of different therapies. And I think among the most important is the understanding of your caregiver, your provider. That is really hard to find. I just had a conversation this very week with my own doctor about this conference, a rather heated discussion, because I think from the perspective of medical providers, it is difficult to treat patients with chronic pain. In fact, he said it's a pain. It's a literal pain to treat patients with chronic pain. And I said, well, it's more of a pain to be one. And that is where we're at. I think in a lot of places, that's what we hear, that yes, they want us to be extremely grateful and feel a little bit guilty that we have this problem that just won't go away. So hopefully today there can be a broader understanding from everybody's perspective. And so I'd like to start. This again is an interactive panel. We're going to get all of these people talking together about what they think they could do to help chronic pain patients. In the end, you're going to talk about Paula's case and some of the things you've learned here to do and see how you might approach a particular case with a chronic pain patient. But let's start off by talking, how big is this problem? We've got 75 million people apparently diagnosed with chronic pain, and that's enough to get the NIH's attention. So I would like David, if you could just start off to tell us, what is your assessment of what this problem consists of and means in society today?
Yeah, I think it's more like 100 million people now is being estimated by the Institute of Medicine that are in chronic pain. We're very concerned at the NIH. It means a very lot to people in the United States. What we're doing at the NIH, our bread and butter efforts are to try to find new cures. And this education initiative, I think, was brought out because we just understood that a lot of times there's not enough knowledge out there, so even if we brought tools forward, it's not being used well. It reminds me of the bumper sticker, you think education's expensive, try ignorance. And I think we're in a case where there's a lot of ignorance about how to treat pain, and people like Paula suffer for that. What we're doing, our bread and butter, again, is to develop new treatments and get them translated into practice. Just a few of them we have coming along. Resinifertoxin, it kills C fibers in your spinal cord. We're trying it on chronic or stage 4 cancer patients, and it's working very well for them. It's letting them live their last days in a lot less pain without opiates. We have a lot of research on glia cells. Our brain, we talk a lot about neurons. They're your classic brain cells, but 85% of your brain is glia, and they're kind of the forgotten majority. They're extremely active. They communicate with each other. They get all fired up during chronic pain states, and they squirt things out, various chemicals that exacerbate chronic pain beyond any injury. So we're looking at ways to stop that. And a number of others, cannabinoids. NIDA, the institute I'm part of, is the leading researcher on cannabinoid for pain research, and there's a bunch of different approaches. So in that direction, I think we're doing a lot in terms of trying to find new treatments. But it was just so frustrating that the knowledge that exists now wasn't being used effectively enough that we should enter into that arena too.
So that's good to know. Now, these medications basically work under the premise that it's neurological, that there are connections in the brain that are causing pain?
A lot of pain is in your brain, yeah. A lot of pain is changes in your brain that happen that then the pain continues because of those changes. You can see David Borsuk, Harvard, has done research on showing brain changes associated with chronic pain, and he finds that there are areas of your brain that normally are devoted to pain. In chronic pain patients, they become larger. It's almost like the brain understands that there's a lot of information about pain coming in, and it needs to devote more resources. Sort of like the analogy of the Eskimos that know all sorts of different ways to describe snow. Well, pain patients become real experts on how to describe and feel pain, and a lot more of the neural and glia mechanisms are devoted to it. And so that's part of the problem. You don't need to understand pain that much. Your brain just doesn't know how not to pay attention to it.
Right. And yet I think that is one of the problems, that it's not so qualitative, not quantitative. Do you think that that is true, Kathleen, that a lot of the problem is that you can't necessarily see or measure a person's pain, that you really are dependent on what a patient tells you?
Shall I answer it, Kathleen?
I'm sorry,
Judy,
Kathleen.
that's okay. I'd love to answer.
I just met all of you, so either of you, why don't you go ahead and take it? I'm sorry.
Yeah, go ahead. I guess it's the person who has the pain that is experiencing it. Sorry. And if the person can communicate, I think Paula is such a perfect example of how someone in a very articulate way can explain the pain issue. And so I know we need better diagnostic methods, and I love what Dave is saying, because you come to a physician or a nurse practitioner or a PT, and you don't know, and especially with something like fibromyalgia, there's frustration about it's not a broken arm, or you don't have a scar or something. So the diagnostic imaging and the different genetic studies, I think, are so critical. But it's the person who's experiencing it, and you've had the greatest example of different people here this morning. They are very articulate about what's happening. So it's my philosophy to listen, and I think you said that, and different people have said that. In Canada and worldwide, it's 1 in 5 people, 1 in 5. And genetically, the problem is that it could be you or me if something happens to you. We've just finished a study after coronary artery bypass patients, and some of your parents, grandparents, will have a bypass. And we were looking at risk factors 2 years down the road. Why do some people still have a persistent pain problem? 10% of people. And what is interesting but not surprising to me as a clinician is that one of the risk factors is their pain management in hospital immediately following surgery. So, if there's a way we can prevent some of the persistent pain, we should do it. And if we can't prevent because things happen, we sure need to be asking you, I think, and also working towards better drugs, using our colleagues. I mean, Kathleen and I were talking, it's got to be me, I'm going to hit you on the head with this. We all have to work at it. We've all got different tools. I think you've heard that, and we need to use them together.
Kathleen, did you want to add anything to that? And I guess the other question I want to ask is that it seems to me that traditionally pain specialists and physiatrists have treated pain, and it feels like they're fleeing from actually treating chronic pain patients for fear of prescription drug abuse. They don't want to follow the patients. They're being sent now to primary care physicians, and primary care physicians don't want to do it either. So is there anybody out there you think who really wants to take on this problem or treat patients?
All right, so that's a really good question. It is a big problem because I don't think there is anyone who wants to take on this group of patients. It's a problem, and partially I think they don't want to take on this group of patients is because they don't know anything about them. They get no education. You've got 7 hours in medical school. I just did a survey, 20 hours in PT school. I'm excited. So that's better, not as good as the vets, but at least we get 20 hours. But every discipline doesn't train you, so you're scared to death to take on a patient because you don't know what's going on with them, you don't know how to treat them. So we have to get back to education of existing people and other people. So I think that's a really good point. And going back to, I don't know how many physicians you've seen or how many healthcare professionals you've seen. If they were trained from the beginning, we might not have to see as many. It is difficult. They don't make as much money off of patients who have chronic pain because, you're just managing them on a regular basis. There's no procedures. You don't do a lot of stuff to people. You manage their pain. You have to take more time because you actually have to listen to them, figure out what's going on with them. That takes more time. And so I think overall it's a whole big issue. So you're right, all the specialties are not wanting to see them anymore. Family care doesn't because they don't know what to do with them. And so it's hard to find someone who really does. Of course, there's great clinicians out there that do want to see, but there's not a discipline that's kind of taking it on as this is the discipline I want, and I want to do this for my whole career, for my whole life. So hard to find people like that in every community. So I think, but if we educate people, I think we'd get more people excited about it because they'd know what to do when a person came in the room.
Right, and let's talk a little bit about what to do. I mean, physical therapy can play a huge role in this. I know that yoga really has saved my life, and I don't exaggerate. And you know, you'll go in, if you are a chronic pain patient, you'll go into something like that screaming in pain and thinking, I am so not moving that arm or that leg. And when you do, it is amazing how much better you feel. Is that something you try to convey to
Yes.
patients? Go through the pain because it will be worth it.
Right. So that goes back to the fact that when you have pain, you shut down, you stop doing things, or maybe you didn't do much anyways to begin with. So now I haven't exercised in my entire life, and I'm 50 years old, and I've never actually, run for the last 30 years since I was a kid. So now I need to go do something. So partially the disease itself sets you in a position in which physical activity just makes it hurt in the beginning. And so you have to get over the hump. And we know that if you can get over 2 or 3 weeks of a regular routine, then that pain that occurs during the exercise goes away, and it suddenly becomes pain relieving. But getting somebody through that 2 weeks is incredibly difficult. So you might need to have specific pain management techniques to do that. Maybe you need to talk to somebody who can give you a pharmaceutical medication that you can take right before you exercise. Maybe there's some other pain control mechanisms you can use right before you exercise. Yoga's great, you get some stress relieving mechanisms along with it, and then you can get through that and start to get some pain relief. So I think it is very difficult, but it's probably the most effective treatment if you go look at all the studies for every pain condition. It's as effective as every pharmaceutical drug there is. They all have the same effect sizes, so if you talk about actual science, they all work to the same level. Exercise versus drugs versus cognitive behavioral therapy, and if you put them all together, that would be fantastic, right? So what if we put them all together and then see if we can get even greater relief? Most of the studies have all been done on single entities, single treatments. And so I think putting them all together and seeing if we can get even greater relief would be great. But the issue is not, which I think Judy brought up, is not, I go do my treatment and Judy will go do her treatment and the doc will go do his treatment, and we'll all kind of do them in parallel, but we never talk to each other. If we can talk to each other and coordinate, we'll have much better outcomes. That's really where we need to go.
Candace, what's it like for patients who just have been told over and over, we can't help you or live with this? I mean, there is a real mental aspect to trying to cope and deal with this.
Absolutely, and I always take exception to that when I hear somebody say that, I'm sorry, there's nothing else we can do for you, because when I look out there in the years that I've focused on the pain initiative in the state of Maine, what I see is we don't bring in the range of complementary therapies, and we are not as creative as we need to be in helping patients. And it could be any one of us. I think, again, as I mentioned before, if each one of us said, what if that were me sitting in that chair? What would I want someone to do for me? Maybe music is something that reduces my stress, and we found that there's a direct correlation between levels of stress and degrees of pain as well. So we all have different things that soothe us, that reduce our stress, and we need to explore those things with our healthcare providers, with our friends, with our colleagues. It might be music for me, it might be massage, it might be acupuncture, it might be Reiki, there are any number of things out there that we can do in complement to the medications that we use. I think also our individuals who are living with pain, when they go to their provider, they sometimes don't know what questions to ask them to get the answers that they need. Someone like Paula, who has had many, many years of experience, has certainly learned what to ask her provider. I think because the system doesn't support the time it takes to really listen carefully, that can't be done in 10 minutes. It can't be done in 15 or 20 minutes. It takes time, as we've all mentioned before. We need to address the system issues that are really, really obstructionist when it comes to effective pain management. And with chronic pain, Kim, you know, in the state of Maine, we've had such a focus on prescription drug abuse. And indeed, it is an issue, but sometimes it's not abuse, it's something that's called pseudo-addiction, that it means people who really aren't getting the pain management they need present, and some people say, oh, well, they're just drug seeking. They're not, they're asking, they're begging for someone to manage their chronic pain effectively. And only one more thing, we have such an influx of veterans coming into our healthcare system these days who are going to have years of chronic pain because of their traumatic injuries. And most of veterans receive their health care from community-based providers, not from the VA. Certainly that's the case with end-of-life care, but it's certainly the case across the board too. And we as clinicians do not have the information we need about the unique needs that veterans are coming home with for us to be effective in controlling the numbers of individuals living with chronic pain that we are going to see introduced in our society. And for no other reason, we need to prepare now for what we're seeing that's entering our healthcare system, to say nothing of the people in this room and in our communities who are already living with chronic pain.
And there are more degenerative diseases, and the population is aging, and the problem is absolutely growing. I think sometimes we're afraid that medications will keep people from functioning in society somehow and contributing, when in truth, sometimes that is exactly what allows people to function in society. And it is that fear that you are supporting somebody's habit as opposed to helping them that keeps a lot of people from getting medications that they need. Again, it's just part of the problem. As you said, it is a multifaceted approach. But it's, yes, go ahead. Sure, somebody has a question? Not sure where the microphone is.
Hi.
Go ahead.
Hey, Paula, I have a question. My name's Ori. I'm over here. I'm from Minnesota. I was actually in Winnipeg once. Nice town. You said, sometimes it's hard to get out of the house and to get on, with life and meeting people. How do you avoid becoming isolated? And are there kind of like groups, or are you able to reach out to other people with maybe similar condition as yourself? We're the same age. I'm also 25, so I'm just kind of imagining, what I would do in your shoes. And also, I'd like to hear more about your advocacy and those kinds of things you're involved in.
Okay. Well, it helps. Well, I don't want to say helps, but I've had it since I was 13, so imagine your entire adolescence and adulthood being based around this in a lot of ways. So, you get used to it. But I actually want to say the internet, it's been a massive help, and especially having access to all the media I could ever want online. That's been massive, because for me, distraction is the way I can disassociate myself from the pain. So really being able to distract myself with just, I have my laptop in front of me, I have my cell phone in my hands, and I have my TV at the foot of my bed. And I use them all at once. As for advocacy, I said I really want to get into it. It's only really been in this last year that I've felt emotionally stable and physically stable enough to even consider it. Up till now, honestly, focusing on my pain has been extremely painful, and talking about my pain, and the thing with the internet is I don't want to typecast, but I find a lot of the internet groups for CRIPS patients and honestly just support groups in general online, they can be very depressing. Everyone just posts how much pain they're in and how much it sucks, and then someone else posts how much their pain is and how much that sucks. And I mean, you know, you get some people being like, oh, be happy, be positive, and think happy thoughts, and neither of those are the most effective, I would say. So I've been kind of wary about doing it in person. But I mean, it's only been very recently I've had any contact in real life with other CRIPS patients, and it's mostly, like, it's a pretty rare disease. I mean, I'm not really sure what the proportion of people that has it. I've heard a bunch of different numbers, but I mean, it's not one where, you know, like, there's a lot of cancer advocacy groups or something, you know. I wouldn't say there's that kind of thing for CRIPS, not in the same way. But
I have a little follow-up.
Oh, sorry.
Have you met people from the States? Because I know you were saying in Canada you have the great resources of your healthcare system there. Have you heard stories from people with a similar condition in the United States and how they deal with it in our healthcare system?
Oh yeah, they're not good. It's really not good. I mean, there's one girl, she's the same age as me. She's in Atlanta. We've been talking for a while now, and I almost feel guilty every time I talk to her because, you know, I'm saying, oh, I want to see this doctor and that doctor, and I'm on all of these drugs, and she's, I don't want to say the word screwed. But I'm a guest here, and I don't want to be unkind about your system, so I will pass the microphone on.
Thank you. Okay.
Same microphone. Again, Paula, we appreciate you being here.
Thank
Getting
you.
out of bed is a difficult thing on many days. Getting from Winnipeg to Maine can only be astronomically more difficult. A question actually that I was curious, you know, for instance, if NIH doesn't even have an answer for your disease, you know, what are medical students going to know about this? But do you have maybe 3 to 5 things of the best treatments that have worked for you that, you know, if somebody in our practice or whatever comes to us with a similar issue that said, well, these are the things that I heard from somebody that it did work for, maybe you can share those insights.
Okay, well, first I want to say that everyone's body reacts very differently to medications. So what might have helped me might be really awful for someone else. But the first thing that immediately comes to mind is nabilone. It's essentially, or it is THC. And my doctor chose it over medical marijuana because this way I get a regulated dose with every meal or whenever I have to take it. With each pill, it's all the same, and I don't get high, so I can function on whatever level I can function because of the opiates. What that did was it calmed the pain spasm. So what used to happen was every time something made my leg hurt, which is everything, it would sort of echo and then it would burst and then another burst and it would get worse and worse and worse. And because of this, I couldn't actually put my foot to the floor for a good 4 years. I literally couldn't touch it to the floor. So I was on crutches. And what the nabilone did was it got rid of those and I was able to walk. I use a cane, obviously, 2 canes often. And I do use a wheelchair for longer distances quite often, but I mean, it's made a massive difference in my life. The memantine has been really excellent. The ketamine, I mean, it helped me, but it caused so many side effects. But what it did, the number, like the pain number out of 10 never went down. But the analogy I used at the time was, if you're ever out in like minus 30 weather, I'm Canadian, what am I going to use this analogy, what can I say? And you're out in the, with the Arctic wind out, or I guess off the ocean for you guys, and it goes right through you, the wind just goes right through. And you put on a parka and you put on a toque, and the weather outside is no less cold, the pain is just as bad, but the intensity of it is massively reduced. And that was, I mean, I honestly wish I could stay on ketamine, and I wish it had worked for me, but it didn't. But the memantine gives me some of that, and that's been huge.
All right, we don't have that long, so I just want to make sure we do get a chance for everybody to discuss what would be the best interdisciplinary approach to treating chronic pain patients. And wouldn't it be a good idea to establish something like that so that doctors, medical students, nurses could have some kind of a guideline that included all of the different therapies? I guess, David, would you think that in addition to the research you're doing on medications, that there's something NIH could do to help doctors know how to proceed?
Yeah, that's a difficult question. And we went into developing our centers of excellence with the idea that the pain champions that were there knew how to do things, that they could get the courses into their schools, and they can convince people to teach it. And our project's just unfolding, but we're letting them do their own interdisciplinary, interprofessional education. It's the way that works for them, and it might change. And so frankly, I don't want to prescribe the right way to do it, but I do think the bottom line has got to be ingrained early that this is good for patients and a good thing to do, and that perhaps they can figure out what the best scenario is for working together.
I actually have a thought on that. I actually went to the Mayo Clinic. My doctor asked Manitoba Medicare to pay for me to go, and they did. And in 2 weeks, I was able to see doctors from all different specialties, as opposed to seeing one doctor, then weeks later or a month later, someone else, weeks later. They were all able to see all the files all at once. They talked to each other. They called each other from the same building. And that, I mean, I would say look to the Mayo Clinic, honestly. Because if my pain doctor and my dermatologist especially could work better together, I mean, I don't know if they have any other ideas that could help me, but I think at least in theory there'd be something there.
I think something like that is terrific, but unfortunately it's not available to many, as you found out yourself. For me, it is to educate health professionals early on that pain is not something that you kind of disregard. It is a priority for all of the health professions, and there are some excellent assessment tools, there's evidence-based guidelines, but if people don't ever learn about them, then when someone like Paula goes for help, they mean well, everyone means well, but they're scrambling because they don't know that they have colleagues with particular expertise, and they don't necessarily have the background. So I really, really, really think that today something like this is the way to go. And could I put one more comment? I do not like the word chronic pain. I think it implies there are no answers. And I like the word persistent pain because I'm hoping that all of us will keep going. We've got to keep going in all of our disciplines to find a way to help people like Paula.
I think that's very true, and that there always are ways to improve somebody's quality of life. And if you just keep thinking about that, what could I do that would make it a little bit better? A little bit better is a lot to somebody who's living in pain. So don't give up just because you as a physician think, I can't cure this, I can't fix it, so I'm done. Because that's not what it's like for the patient. The patient is still hoping to move forward and find ways to improve their quality of life. And I know, as my doctor said, he said it's it's difficult for us to tell when there's a patient who is just coming to us for prescription drugs, as opposed to somebody who really needs it and is in pain. And all I can say is that's not my problem. The patient's problem is to try to find help. So I wish you luck in trying to discern if that's really the biggest concern about why chronic pain or persistent pain patients aren't being treated right now, but just remember that that's not everybody's story, and I'm afraid we're throwing out the baby with the bathwater in our attempts to deal with what certainly is over-abuse of prescription drugs in Maine. Anything else that anybody would like to add?
I'd just like to say that I think every discipline should talk to every other discipline, that the patient is telling you things, but you need to call the physician if you're a physical therapist. If you're the physician, you need to call the physical therapist. You need to get on the phone. You need to talk to each other. You need to email each other, and you need to be talking about this person in order to do that. When someone walks in your door, don't ask, okay, what am I going to do for him? Ask, what can other people do for him as well? And so that you keep an open mind to the rest of what medicine has to offer beyond your own discipline.
Just one thing, because I know we're out of time. This is about social change and culture change in medicine, and it's taking years to realize that the issues that we all deal with are so complex because we're complex human beings. It takes all of us working together to really affect the kind of change that we want to see. And we haven't seen this kind of achievement yet in health professions education, but at least UNE is working toward that goal. So thank you.
Yes, it is wonderful that UNE is addressing this issue. And I would say just in closing that the one thing I think goes a long, long way, I heard Paula say it, I know other patients would say it, is empathy. Just remember that when patients come to you, we're very willing when there's an acute pain problem. You go to the ER, the first thing they do is throw pain meds at you. You don't even have to tell them what's wrong. They're just hooking you up to the IV. But a chronic or persistent problem, people draw back from wanting to treat that and take care of that when really the pain levels are not that much different and sometimes more excruciating than what cancer patients even go through. I mean, it's very sad when you hear pain patients say, I kind of wish I would be diagnosed with something where somebody would care. But believe me, that's how some people feel. So just carry that thought with you and remember that kindness goes a long way, and it also goes a long way in therapy and in treatment. Dora mentioned all the work I do in the community. Just like Paula said, when I get my mind outside of myself and focused on the fact that there is always something each of us can do to make the world a better place, your health will improve, and certainly it will help make a difference in the world, so you're not just asking for help, you're giving it as well. So have a great conference, and thank you so much for addressing this issue. I think we're on the right track.
Thank you, Kim. Thank you, panelists, Paula especially, for their very moving address. And so we've been talking about interprofessional education all morning. I don't know if you've been listening, but now we're going to do some. So this is the time for folks to gather in their round tables where you're sitting to get to know each other at your tables. And throughout the audience are a number of facilitators who will help to guide the discussion as you need it. There are also facilitator packets on your table, so you can self-direct to a certain extent if you don't have a facilitator handy. And let's do some of what we've been talking about all day. Let's learn about each other, with each other, and from each other.